வந்துக்க Good morning, Ninaven.
Right.
Apurva bhai, good morning. Good morning, Pankaj bhai.
Very good morning, Rupesh bhai. Ready?
Ready. આ બધું
શોર્ટ
તમે લોકો
નોટિસમાં સારું ગોઠવાઈ ગયું છે.
હે?
શોર્ટ નોટિસમાં સારું ગોઠવાઈ ગયું.
હા ના સરસ બરાબર છે. અભય દલવી સાહેબ બી આવી ગયા છે એટલે પિંકીબેનને કોફી કાકો ઉપર આપ્યો. પિંકીબેનને ઉપર આપ્યો કોફી કાકો ઉપર આપ્યો છે નીચે આવો.
Apurva, are you there?
અવાજ ના કરે.
Yes, he was there, just he has left.
I think so.
હા સિંભાઈ.
Apurva?
હા જોઈન થઈ ગયો તમે. હા હા ઠીક છે.
હવે સાહેબ આપણે એ રીતે Apurva, are you? I think
A headphone set.
his audio is off. Rupesh bhai, I am clear? I am audible?
Yes, very much audible.
So we are planning, I will start with the function. Ninaben will give introduction, then you will speak for 1 minute, then Ashwin and Dalvi sir will officially, you will Dalvi sir officially inaugurate it, right? And I think Rashesh is going to join, otherwise Apurva can give thank you.
Okay.
And what we have planned, we are going, ASI is going to declare 3 prizes for paper and 3 prizes for posters. Right, that I will tell. Kaushik has said so, so we'll do it.
Okay.
And so for that we have some judge which are not announced.
Okay, fine.
They will do independent assessment because the other will be
morning,
localized
Ashwin
only.
Good morning. Good morning. Good morning, Pankaj ji.
Good morning.
Good morning, Divesh.
Good morning.
Good morning.
દિવ્યેશ આજે માસ્ક કાઢો ભાઈ.
દિવ્યેશ તો
આજે માસ્ક કાઢ નાખીએ. યસ ના ડાટા લુકમાં શું રૂપેશભાઈ તમારી જે ગાડી હોય
ક્યાં છો?
હે
ટ્રેકિંગમાં છે?
ના કમાટી બાગમાં છું પણ નીકળી ગયો.
ઓકે.
પેલું હતું એટલે નીકળી ગયો.
ના બનાવવાનું છે. હું 10:30 જઉં છું આવું હોય તો.
ક્યાં આગળ?
પાવાગઢ.
ના મીટિંગમાં નથી આવવાનો 1:30 વાગે?
ના 1:30 વાગે છો ને તમે ભાઈ અમારા રિપ્રેઝેન્ટ વડીલ અમારા.
હું કરું બંધ. બેટા આમાં કેમ નથી?
મારા બાનું 10મું છે ને આજે રૂપેશભાઈ.
હા ના ઠીક છે બરાબર.
મુંડન ને બધું કરવું પડશે ને.
હું વાત કરે?
હા પપ્પાનું મુંડન ગાડી કાઢવાની એવું છે. અશ્વિનભાઈ પ્લે શૂટિંગ ચાલુ છે અત્યારે?
હા ચાલુ છે.
ઓકે. બપોરે કદાચ છોકરાઓ કહેતા હતા જવાનું એટલે હું એની જોડે કોર્ડિનેટ કરી દઈશ.
એની જોડે કોઓર્ડિનેટ કરી દેશે.
તમારી પાસે છે નંબર એનો?
મેં બીનાને તને થોડી વાર મોકલી આપું.
ઓકે બીનાને શેર કર્યો છે ને તો પછી એની જોડે કોર્ડિનેટ.
સોરી.
દલીવ સાહેબ ક્યારે જોઈન થવાના છે?
9 વાગે કહ્યું છે આપણે પહેલા
9 વાગે સાહેબે કીધું છે. મેં કાલે એમને ઇન્વિટેશન પંકજભાઈએ કીધું હતું એટલે મોકલી આપ્યું છે.
ના બરોબર છે એટલે બધાએ જ મોકલ્યું છે આપણે.
ના બરાબર છે કે એ તો પ્રેસિડેન્ટ તરીકે મોકલવું જ પડે આપણે બધાએ.
હા એટલે ખાલી આવી જાવ તો આવી જાય અલગ વાત છે પણ
આપણે ઓફિશિયલી મેં એમને WhatsApp પર ઇન્વાઇટ કરેલા છે.
બરોબર છે.
અને એમને લિંક બી ફરી મોકલેલી છે.
ગુડ મોર્નિંગ કૌશિકભાઈ.
Good morning, Rupesh bhai. Good morning, Pankaj bhai. Good morning, Divyesh.
કેમ છો કૌશિકભાઈ? ગુડ મોર્નિંગ.
Good morning, Ashwin bhai. Good morning.
ગુડ મોર્નિંગ કૌશિકભાઈ. ગુડ મોર્નિંગ.
એકવાર ફંક્શન પતી જાય પછી આપણે બધાનો ઓફ કરી દઈશું એક્સેપ્ટ ધ પાર્ટિસિપન્ટ એન્ડ જજ.
યસ બરાબર.
હા
and two station will go on lively together, station 1 and 2. Approval is there, I think. Everything is worked out fine?
Yes sir, everything is fine sir.
Okay, he is the main person who has done all these things. Hard work is done by him, we are enjoying the fruits.
Yeah.
me and two third year residents.
Good morning everybody.
Good morning Kaushikbhai.
Good morning Kaushikbhai.
Rupesh bhai, good morning.
Good morning, Ninaben.
Good morning, sir. Good morning.
ગુડ મોર્નિંગ.
Oh, big boss is here.
Apurva.
અપૂર્વ ભાઈ ગુડ મોર્નિંગ.
Vinit.
Good morning.
Samir.
પંકજભાઈ મને લાગે છે બધાનો ઉત્સાહ બહુ સારો છે. એક્ટિવ કરો આ બધું કરતા.
શું કરીએ?
એટલે લેટ અસ હેવ અ ગેધરિંગ, સ્મોલ ગેધરિંગ. આઈ ડોન્ટ સે કે કોન્ફરન્સ, પણ 25 જણ ભેગા થઈને એક વર્ષથી મળ્યા નથી. આમ આવી રીતે
15 દિવસ જરા ખમી જાઓ, 10-15 દિવસ બધું થઈ જાવ તો પછી આપણે બરોડા મળીએ.
હા, આપણે 15 ફેબ્રુઆરી પછી, અરે 15 જાન્યુઆરી પછી વડોદરામાં જ ગોઠવીએ રૂપેશભાઈ.
યસ, ગાઈડલાઇન્સ કેવી આવે છે જાન્યુઆરી પછી જોઈએ.
સારી આશા રાખો, સારી આવે હવે.
યસ, આવશે.
બહુ થયું હવે.
ગાઈડલાઈન નો કોઈ સવાલ નથી. અત્યારે બી 50 જણ સુધી મેરેજમાં ભેગા થાય છે, 100 જણ સુધી મેરેજમાં ભેગા થાય છે. 50 જણ ભેગા થવામાં કઈ there is no hurdle.
પોલિટિકલ કોન્ફરન્સ તો બહુ મોટી થાય છે.
રાજાઓને કોઈ કઈ ના કહી શકે ભાઈ. રાજાઓ તો બધા.
અરે પૃજલ, અપૂર્વા કે અનમ્યુટ નથી થવાતું. અપૂર્વ થી કરી દો ને.
કર્યું સાહેબ એને.
અપૂર્વ, where are you?
Yes sir.
Okay,
morning
great.
sir. Yeah.
Good morning.
Good morning. Good morning.
ગુડ મોર્નિંગ બિલા.
ગુણવંતભાઈ ફેસ બતાવો તો તમે કે આજે ઓળખાતા નથી.
અરે ગુણવંતભાઈ તો ઊંઘમાંથી ઉઠીને બેઠા લાગે છે.
કોને નથી ઓળખાતા રૂપેશભાઈ તમને?
હા, દાઢી કાઢ નાખી છે. તમારો ટ્રેડમાર્ક જતો રહ્યો.
બધું જ છે યાર, કશું કાઢ્યું નથી.
માસ્ક કાઢ્યો ખાલી, માસ્ક
આવે છે.
થોડો કેમેરા ઊંચો કરો.
ગુડ મોર્નિંગ.
ગુણવંતભાઈ નો કેમેરા થોડો ઊંચો કરો એટલે ફેસ બરાબર દેખાય.
હા, બસ બરાબર છે હવે.
પૃજલ પેલા પૃજલ
અમારે તો કૌશિકભાઈ દેખાય એટલે બધા આવી ગયા.
પૃજલ
અને સ્માર્ટ ગુણવંતલાલ દેખાયા.
અરે કૌશિકભાઈ દેખાય એટલે બધા આવી ગયા.
એક મિનિટ પૃજલ
હાથીના પગમાં બધા આવી ગયા.
પંકજભાઈ get ready for the
best. I am waiting for Dalvi only. Everything is ready.
Ready.
Prujal, I think Prujal, are you hearing me?
નથી સંભળાતું લાગતું.
ના એટલે પેલો ઓન છે પણ એનું વ્યવસ્થામાં પડ્યો. Because the best, there will be two administrator, one in one room, be sitting in one room, another one will be sitting in second room. Those two girls will be looking after everything, Julie and Priya. One is my third year, one is Apurva's third year. They three people are the backbone of this whole conference.
Absolutely.
Very good.
And Nina Ben.
અપૂર્વભાઈ,
નીનાબેન તો ખરા જ યાર.
બહુ સારી ટ્રેનિંગ આપી છે બધા રેસિડેન્ટ્સ ને. વેરી ગુડ ટ્રેનિંગ. ગઈકાલે હું બધા પીજી માસ્ટર ક્લાસ ના YouTube પર વિડિયો જોતો તો અપૂર્વભાઈ બધા મોકલ્યા છે.
Yes.
It will be a lifetime learning for all residents.
Yes.
બહુ સરસ.
For any surgeon.
Apurva.
Good morning.
Good morning, Rajan.
Good morning, Pankaj.
Good morning, Rajan bhai.
Good morning,
Good morning,
Rajan
Kaushik bhai.
Good morning, Rajan bhai. Good morning.
Yeah, smarty Rajan.
અરે કૌશિક ભાઈ, ગુડ મોર્નિંગ.
ગુડ મોર્નિંગ.
તો યાર ફોન પર ઉપાડતા નથી, વાત નથી કરતા.
અલે આવું બોલે છે તું યાર.
કાલે કર્યો તો ખરો યાર તમને ફોન, પછી
ઓપરેશન માં હતો અને પછી યાર હું ભૂલી ગયો, સોરી.
ના સોરી ના કહેવાય યાર, તમે વડીલ છો અમારા.
ના યાર વડીલ ના બનાય એમ કઈ મને દૂર કર, પેલા પેટર્ન માં ના ગાલી દે.
તમને પેટર્ન થોડા જો યાર, હવે તમે તો અમારા ગુરુ છો.
પંકજભાઈ દલવીને કોન્ટેક્ટ કરી જો ફોન થી.
હા એટલે મેં મેસેજ મૂક્યો, હવે જોઉં. અરે શશાંકભાઈ જોઈન થયા કે નહીં? બસ તમારી જ રાહ જોઈ રહી છે. ઓકે.
ગુડ મોર્નિંગ સર. ગુડ મોર્નિંગ.
Okay, Rashesh is there. That is best.
Good morning everyone. Good morning sir. Senior.
Rashesh, you are going to give thank you speech. Okay.
Fine sir. Sure.
Okay, that's great.
Welcome by Nina Ben. And then the speech by the Rupesh and Ashwin.
Ashwin, a very short speech, huh?
Short speech.
Airline સાહેબ.
સાહેબ આમ તો આખું વર્ષ કશું બોલવાનું નથી મળ્યું. આમ તો બિલકુલ આવી ચાલે એવી છે.
Short speech in long corona.
રૂપેશ ભાઈ તમારે થોડું લૂઝ કરવું પડ્યું આ વખતે આના કોરોના લીધે પણ શું કહેવાય પંકજભાઈ and us has given you the opportunity to present in front of all the PG students.
હું સાહેબને ફોન કરું છું.
સાહેબને ફોન કરો. બધા લોગિન થઈ ગયા છે, સાહેબને કહો.
પણ એ 9 વાગે પરફેક્ટ 9 વાગે આવશે.
હા એ જ ને. ગુડ મોર્નિંગ સર.
નરેન્દ્રભાઈ.
Okay. So I think you are in station 2, sir. I think so. We are 20 people are talking, sir. Please. There were two. We have specific. I am sending you again, sir. Fresh link. Just a moment. Okay.
સ્ટેશન 2 માં જોઈન કરી બેઠા લાગે.
હા સ્ટેશન 2 માં જોઈન થઈ ગયા છે.
બે લિંક મોકલી હશે ને તમે એમને.
એટલે એ તો મોકલવી તો હા બસ આ છે.
ગુડ મોર્નિંગ.
ગુડ મોર્નિંગ.
અલા સાહેબ આઈને સાંભળતા તો નથી ને કઈ દેખાતા નથી જોકે. Good morning, sir.
Good morning,
sir.
I went on to the other line.
I thought so, sir. That's why I phoned. Okay, so shall we start, sir?
Please.
Sir, आपका वीडियो
sir, video want to see, sir.
अरे सुबह सुबह क्या देखना है?
Okay. नहीं, sir. Nice, sir. Thank you for coming on such a short notice, sir. Good morning, everybody. This is a very spontaneously arranged meeting because we were not knowing we were going to do it before 10-15 days. But looking at the great success of ASICON, particularly paper and poster, we decided that we can think on the same because we did not have a paper poster for our state students. And many were left out and they were going to be attending the exam and they needed their paper presentation. So we did this and there are actually very good response. There were 28 paper and 19 posters are to be displayed. So it was not possible to do it on one station. So we have made 2 stations and 4 sessions in each side. It's a part of our annual conference divided into small part. We'll have a conference later on. It's a part of Bhuj ASICON. The outline, how it is going to be done, it is done in 2 parts, station 1, session 4, station 2, session 4. And we will be judging according to ASICON as the sir had sent the same, we are using it. I think there is no copyright. And the second point was that the AS, particularly Association of Ahmedabad Surgeon, the great Kaushik Bhai had said we should give encouragement to student and we are going to give 3 prizes for paper and 3 prizes for poster. For that, again, like on ASICON, we have some silent judge who are not there and they will be judging them. Rather than wasting any other time, I will hand over mic for a welcome seat to Dr. Neena Ben. Thank you very much. Sorry, she is our president of AS, Association of Ahmedabad. She is a present president. Yes.
Good morning, everyone. This year's state conference has not been done due to the COVID pandemic. So this midterm program is done by Association of Surgeons of India, Gujarat State Chapter, GSC, SAB and AS combined. First of all, my warm welcome to Dr. Abhay Dalvi, sir, President of Association of the Surgeons of India. I thank him for accepting our invitation in a short notice. I also welcome Dr. Rupesh Shah, sir, who is President of GSC ASI, and Dr. Ashwin Shah, President of GSC. I welcome all the judges who are, most of them are the head of the department of all the medical colleges of Gujarat. Under the Association of the Ahmedabad Surgeon, we are doing activities like twice a week lectures and master classes on Sunday. Before the pandemic, we were doing this type of master classes in BJMC Hall, which is linked with 70 medical colleges of India. And by doing this, we are doing all the academic activity actively, and all are supporting for that in the all over the Gujarat. It's my pleasure to announce that 3 prizes will be given from the arts. First prize will be of 5,000 rupees, first number. Second will be 3,000 rupees for the second number, and 1,000 rupees for the third number. Same way, we will also prizes for the poster. That will be of 3,000 for the first number, 1,500 for the second number, and 1,000 for the third number. Prizes will be given by the Association of the Ahmedabad Surgeon. And for further, I will hand over the mic to the Pankaj.
All done. All set.
Pankaj,
you unmute your mic.
Julie will have to do that. Julie, please unmute your mic.
તમારું mic unmute કરો.
It is unmuted from the main center.
પંકજભાઈનું mic unmute.
very warm welcome to all. Today morning, we are present.
So I welcome Dr. Rupesh Bhai for giving his speech. Rupesh Bhai, GSC President.
Very warm welcome to all. Today morning, we are gathered for a poster and paper presentation, particularly for the junior residents.
Yes, sir.
We all had witnessed. It is tradition of our with the help of our seniors and our professor. We are our aim is to teach and learn by teaching them, to particularly to our junior colleagues, our junior residents, and this is the part of them. We are very much fortunate to have our ASI President, Dr. Dalvi Sahib. I welcome him. Dr. Abhay Dalvi is I think very familiar to us. We feel very homely when we have any query, we want any suggestion. We are very we are, I think, we have no anytime we are not having any hesitation to call you, sir, and take guidance of you. Thank you very much for that, and I congratulate you for being the president of ASI. Very well deserved, sir, and I hope we will have very good academics this year, whatever may be the condition, whether it may be virtual or whether it will be physical. I heartily welcome you, sir. I welcome all our senior friends and our junior colleagues. Not taking much time, I wish you all will enjoy this feast this morning. Thank you very much.
I welcome Dr. Ashwin Bhai for giving short speech for inaugurating this.
Good morning. Good morning.
Good morning.
I'm audible?
Yes.
Yeah.
Yeah. Good morning, all, and congratulations first of all to the Dr. Abhay Dalvi sir for the being a president of All India Surgeon Association.
Ashwini, you are not audible. You come little bit close to your laptop. You are not audible.
No, I think his mic is muted.
Okay.
Ashwin, your mic is muted.
Okay, I think there is some problem because of our own inexperience. Okay, I think we consider it Ashwin Bhai has. Okay, Nina Ben.
I welcome Dr. Abhay Dalvi, sir, for giving some remarks regarding this program. Welcome, sir.
Good morning. Dr. Bhuvi, can you mute?
Bhumi, you unmute your mic. Bhumi, unmute your mic.
Bhuvi, please mute. Thank you. Good morning, everyone. At the outset, let me congratulate Gujarat for starting this academic activity. It has always been my dream through last 36 years that I've been teaching. And I'm really seeing good people out here who are actually trying to teach the PGs, something which is very close to me. And I can see many friends of mine hooked up here. Let me make a big announcement straight away. I am going to nominate Dr. Pankaj Bhai, a very unassuming person, but good at heart and something like me who talks very frankly. I'm going to induct him in the academic council to further.
Thank you, sir.
Thank you, sir.
And he will.
Congratulations, Pankaj Bhai, and thank you.
Thank you. Please continue, sir.
His head and refuse for sure. And he is going to be the architect of one of the architects of academic council, who will look after not only welfare of the PGs, but all the surgeons who want to learn. And he will be closely associated with not only ASICON 2021 academic program, but also the RRC and other academic programs in the Western Zone. So congratulations to Dr. Pankaj Bhai. This is an announcement I'm making without permission of the EC.
Oh, thank you, sir. Thank you very much.
And there is an overwhelming response from the state of Gujarat to appoint you. Behind your back, I've been doing some homework, and that is the result of the homework. So congratulations to you.
Thank you very much, sir. I am humbly accepting it. Yes.
I can see Professor Rajesh Shah sitting and listening very quietly. Rajesh Bhai, your responsibility as far as Gujarat State, and Kaushik Bhai, two people. I always get confused between us and the other this, and efforts which went on to amalgamate the two associations, both at Ahmedabad level and state level. And at any time you want my help, I think we should go through. That's my second thing. And all the PGs who are listening, remember, these sort of things do not come out of just spontaneous activities. This thought process goes on and has been accentuated by the corona. And we have learned now that unfortunately, we cannot teach you live operative, etc., etc. So the next thing after papers and posters, I would earnestly request the teachers out here to have some good videos of simple operative procedures, which can be shown to the PGs, because they have lost a lot of operative experience. And that's my priority. I have been working with the director of academics to put this into practice. There are difficulties. Remember, difficulty is we want something which should be done properly, and we do not want how I do it rather than how it should be done. And that is the way I request all the academicians out here to identify people. May it be a senior resident, may it be a professor and head of department. But try and get videos. I can promise you, if there are good videos, I will definitely use them on ASI platform. Let me again take this opportunity to congratulate Nina Ben and others who have taken this lead in teaching PGs, and all the best to Gujarat. Thank you.
Thank you, sir.
Thank you, Abhay Dalvi, sir. By this, we inaugurate this program and we will start judging these papers. Thank you, everybody.
Rashesh. Thank you, sir.
Yes, sir.
Please say your piece. Yes.
Hello.
Yes, he is our Ask Secretary. Yes.
Yeah. So it is really an honor for me to be present among all the stalwarts of surgery in the state of Gujarat, as well as Professor Dr. Abhay Dalvi. We always looked upon him as our mentor, and I considered myself fortunate to be present over here. And we will start the proceedings. I hope I will be in station B, right, sir?
Station 2.
Station 2.
Okay.
Anything else, sir, that I have missed that you want me to?
No, it's okay. Thank you, sir. Thank you very much. Thank you for remaining present, Dalvi, sir, and everybody else. So without wasting much of our time, we will start the station 1.
Thank you, Dr. Dalvi, sir.
Yes.
Thank you, Dalvi, sir.
I hand over the proceeding to Aprujal. Now let us start station 1 and 2. So whoever judging the station 2 and the students who are in station 2, please join the link through station 2. And station 2 will start at 9:30. Station 1 we will straightway starting. Thank you very much.
Yes, sir. So now everyone's mic will be muted except for the participant and the two judges. The judges for station 1 session are Dr. G.H. Rathod, sir, and Dr. Vinay Johnson. Julie, make everyone's mic. And the first participant is Dr. Riddhi Dhanak from PDUMC Rajkot, with her paper presentation of a prospective study of incidence, predisposing factors, and management of a prospective study of incidence, predisposing factors, and management of anti-abdominal wall hernia in females. Dr. Riddhi, are you present?
Yes, sir.
Please start your screen sharing.
Yes, sir.
Prujal, judge this.
Prujal, can you announce the names of judges?
Judges.
Sir, I think my microphone was muted during it. Sir,
Okay.
I'll repeat, sir. I'm really sorry. The judges for session 1 on station 1 are Dr. Gunwant Rathod, sir, and Dr. Vinay Chauhan, sir. And the first participant is Dr. Riddhi Dhanak. She will start her screen sharing now, and she has already done it, and we can proceed with it. Thank you, sir. Sir, Gunwant, sir, with your permission, we can proceed with the session.
Yes, please start. Vinit, are you there?
Yes, sir, I'm here, sir. Good morning.
Okay, thank you. Please start.
Good morning, respected teachers, faculty, and my colleagues. Today I'm going to present a paper presentation on my topic, that is a prospective study of incidence, predisposing factors, and management of anti-abdominal wall hernia in females. The introduction. Hernia is protrusion of viscus or a part of viscus through an opening in the wall of its containing cavity. Abdominal wall hernia presents at sites where aponeurosis and fascia are not covered by striated muscle. The most common ventral hernias are incisional and paraumbilical hernias. The epigastric and hypogastric hernia presents above and below the umbilicus respectively. Spigelian hernia occurs when the abdominal contents protrude through a defect in semilunar line, that is the arcuate line, or also called the line of Douglas. The incidence of recurrent incisional hernia increases with each attempt at repair. The midline, there is the study which shows that with the midline incisions, there is a higher rate of incisional hernia compared with transverse incision and paramedian incision. Now, the advances in the basic and clinical sciences have allowed a better understanding of the pathophysiology of the hernia formation. It is known that based on Pascal's principle of hydrostatic forces and law of Laplace, that a hernia will continue to enlarge over time if not treated. The aims and objectives of my study is to know the incidence and predisposing factors of anti-abdominal wall hernia in females, so that it will help to prevent the occurrence of anti-abdominal wall hernia in females and for proper management of it. The materials and methods. It is a prospective study and the duration of study was of 2 years. After obtaining Institutional Ethics Committee approval and written informed consent, we took 50 females between the age of 18 to 65 years during a duration of time from September 2018 to August 2020 in this prospective study, which was conducted in PDO Medical College in Rajkot. Their clinical and demographic data were collected. We took the history about the duration of hernia, the progression in size over time, the associated complaints like pain and swelling or abdomen, vomiting, reducibility, chronic cough, constipation, difficulty in maturation, abdominal distension. Also, the history about the number of pregnancy, previous operations, and their types and incisions. Then the information regarding the management of patients, like the type of operation, was taken. In inclusion criteria for my study, the female patients between age of 18 to 65 years were included, and they were giving consent for the study. All the male patients were excluded. Patients below the age of 18 and above 65 were excluded, and strangulated or complicated anti-abdominal hernias were excluded. After my study, the following were the observations and the results of my study. In our study, 34% of the patients had incisional hernia, which is the most common type of ventral hernia in our study. And I have mentioned port side incisional hernia, which is also a part of incisional hernia. It was 16%, followed by paraumbilical hernia, which was 30%. Of the patients had paraumbilical hernia, and only 20% had epigastric hernia. As previous surgery, as incisional hernia was the most common, the types of surgeries that led to incisional hernia in our setup was the most common surgery that was performed previously was laparoscopic tubal ligation, followed by abdominal hysterectomy. About 30% of the patients with abdominal hysterectomy with financial incision mostly were developed incisional hernia over a period of time. The common predisposing factors for development of ventral hernia in our study included past surgery, multiparity. It was an associating factor that led to developing of weakness of anti-abdominal wall over time. Like if the multiparity was one of the important predisposing factors for ventral hernia. Anemia, hypertension, and diabetes were also significant predisposing factors. In management of ventral hernia in our setup, most of the hernias were managed by on-limb meshplasty, followed by in-limb meshplasty, and only 2% of the patients were treated by laparoscopic IPOM. Discussion. The major cause of postoperative herniation is wound infection, as it leads to facial necrosis with resultant loss of integrity of the closure. Incisional hernia account for 80% or more of ventral hernias that surgeons repair. The prevalence of incisional hernia increases substantially when certain risk factors for postoperative hernia, such as multiparity in our study, incisional hernia, including port side incisional hernia, accounted for 50% of ventral hernias, followed by paraumbilical and epigastric. Anemia, diabetes mellitus, obesity, alcoholism, smoking has been associated with higher percentage of postoperative hernias. In our study, 6 patients were anemic, 6 were diabetic, 46 patients had multiparity, and 31 patients had previous past surgery. I have compared my study with a study of Karnataka Doris Swami study.
Time's up for the participant for presenting. Time for questions. Hello.
Vinit, you can start.
Hello.
Yes.
Riddhi.
Yes.
Hello, Dr. Riddhi.
Yes, sir.
You talked about port side hernias. So what was the common port side common areas where port side hernias were there, and what was the cause?
Most commonly, it was because of laparoscopic tubal ligation, and so infraumbilical port site was the most common site where incisional hernia developed in my study.
So any surgical following gallbladder surgeries or something like that?
Mostly
Any
tubal ligation. Most common was tubal ligation.
So what could be the cause in this tubal ligation?
Proper closure might not have been done during surgery at that time. Sheath closure might not have been done properly with proper suture material, which might have led to developing of hernia over time.
So what do you feel from the conclusion? What do you feel that what should be done for to prevent the incisional hernias and port site hernias?
As I mentioned earlier, that for port site hernias, proper sheath closure with a suture, like non-absorbable suture material, would be better, as it will give more strength to the sheath, and that will, and also it is important to prevent post-operative wound infection, and so intraops asepsis and asepsis is an important factor for preventing the hernia in future.
Dr. Rathod sir, you want to ask any question? Dr. Rathod sir?
You continue to ask because he is having some laptop problems, so he is joining from mobile.
Time's up for this participant. Next is Dr. Pratik Chaudhary. Riddhi, can you please stop screen sharing so that Pratik can start sharing the screen?
Thank you.
Dr. Pratik, please come on the screen.
Hello.
Yes, start,
Hello.
Pratik.
Pratik, can you please start screen sharing?
Yes, ma'am.
There is a green button below of screen share.
Ninaben?
Yes. Welcome, Gunanbhai.
I joined.
Yeah.
Vinit?
Yes, sir. I'm here.
I think we can, Pratik, you prepare. By that time, we will go to third student.
So first one is over. There was some problem with my laptop.
Yeah.
First one is over, na? Riddhi Danak.
Yeah.
Now we are starting.
Start with third
Pratik, you
student.
can. Yes, sir. Pratik,
Second.
you can present later. The next participant is Dr. Manohar Kadam. Dr. Manohar.
That is third one. That is third one, no?
Yes, sir. Pratik is having some issues with sharing the screen. So, sir, he'll present after the rest participants.
Okay, okay.
Of session 1.
So now who is starting?
Manohar. Dr. Manohar Kadam,
Yes,
are you there?
screen is not visible. Huh?
Hello.
Dr. Manohar Kadam.
Hello, sir. Good morning, ma'am. Dr. Manohar is here.
Someone else has started screen sharing. Dr. Vimal Vora, can you please stop your screen sharing?
This may be of Manohar. Manohar, is it your screen share?
No, ma'am. It's not my screen. Hello.
Hello.
Dr. Vimal Vora, please stop your screen sharing. Dr. Manohar, you can start now. You can share your screen.
हाँ मैम, एक मिनट.
Hello.
हाँ.
Nothing
there
is
any
seen.
issue?
Yes, I can't see the screen.
Yes, sir. Just 1 minute. मेरे WhatsApp में शेयर नहीं कर सकते.
Inaben?
Yes.
Vinay?
Yes, sir, I'm here.
But things are going on, or it has stopped? I can't
No,
hear
it
anything.
is stopped. It is stopped. I think there is some issue that resident is not knowing
Someone
how
is trying. Someone is trying. No?
Yeah.
Okay, okay. Hang on.
कहीं और पे पड़ा हो तो देख, कहीं और सेव कर.
You can change, Julie.
Okay, sir. I'll go to the next
Announce third.
participant. Manohar, please be ready with your presentation. The next is Dr. Roshan Walvi. Dr. Roshan.
एक काम करने लैपटॉप पे.
Dr. Roshan. I think he is not there.
Announce
Dr. Roshan, are you there? The next is Dr. Forum Mehta.
Hello.
Yes,
Dr. Forum.
Good evening, everyone. Good morning, respected faculties. I am Dr. Forum Mehta.
Yes, Forum, you can start with your presentation.
Yeah, just a sec.
Please make it slideshow. Slideshow, please.
So it is written upward. Slideshow.
Good morning, respected faculties. I am Dr. Forum Mehta, first year resident in SBKS. My topic is peptic ulcer perforation, single institute study. The introduction is perforation is one of the most important complication of peptic ulcer. In spite of the it is a life-threatening emergency. The knowledge of perforation dates over 2000 years back.
Forum, you are not audible.
There is some issue with the network, I guess. Forum?
Forum?
I think there is a network issue.
Yeah, and I think Riddhi is also trying something. Riddhi? Riddhi, unmute yourself.
If anybody else is ready in Roshan or Manohar or Pratik,
I think audio is a problem.
Anybody ready?
Manohar? Dr.
Julie, you
Manohar?
unmute your all five. Julie,
Okay,
you
sir,
unmute all
I'm
four.
unmuting all the participants of session 1.
Unmute all the participants of session 1.
Yes, ma'am. Pratik?
Yes. Yes,
Are
ma'am.
you ready with your presentation?
Yes, I will try.
Okay, start screen share. Is there any issue with sharing the screen, Pratik?
Yes, I will try. Just a second.
Pratik, what is the problem? Let us know.
I'm just this document is not in my mobile.
Pardon?
I'll try to search my document, ma'am.
Anybody else?
Can you
We
share?
are not able to share the screen.
Yes.
Manohar, are you ready with your
Anyone is ready?
Anyone is ready from
Good
session
morning,
1?
ma'am. I'm Dr. Forum Mehta. I'm ready with my.
Yes, so
Okay.
please, for Dr.
Yeah.
Forum, please start.
So everybody stop sharing. Forum, you start sharing.
And please, rest of the participants, please be ready with your presentation.
Forum, start from the
good.
second slide. Start from the second slide.
Yeah, yes, ma'am. The introduction is perforation is one of the most important complication of a peptic ulcer. In spite of modern management, it is still a life-threatening emergency. The knowledge of perforation dates over 2000 years back when the great Indian surgeon Sushruta described it as an parinamasula. Perforated peptic ulcer occurs in 2 to 10% of peptic ulcer disease and account for more than 70%. Mortality rate of perforated peptic ulcer in recent studies varies from 6 to 15%, remains an approximately 30 to 60% in patients with voice score. All the patients enrolled in study were explained about study and procedure and previous history of drug intake such as NSAIDs, smoking was taken, comorbidities were noted, and detailed general and stomach examination was done. All the patients was post-operatively patients were kept NBM for 5 days and slowly liquids and diet was started. The status of the wound. On discharge, patient was started. So this is the peptic perforation. The VA perforation is most common surgical emergency a surgeon encounters during his residence and practice life. Early diagnosis, preoperative correction of shock, operative management with gram sprays is the treatment of choice.
Monan bhai, you can ask question.
Dr. Forum. Dr.
Yeah,
Forum. Hello. Can you
Yes.
hear me? Hello.
Yes, sir.
Yes, you have studied 50 cases. So what is the incidence of male and female? And what are the probable causes of the peptic ulcer in your study?
So the incidence is more in male comparative to female, and the NSAIDs, history of NSAIDs, analgesics, or alcohol intake. Most common cause for that is that.
So what was the most common site?
Some most common site for peptic ulcer perforation is the duodenal ulcer is more likely to perforate, and in gastric ulcer the anterior side is the most likely to perforate.
No, in your study, I'm asking about where was the most common site? Was it prepyloric, or was it duodenal, first part of duodenum, or was it a gastric ulcer?
Most common is the duodenal first part.
So what was the treatment you gave?
So what treatment for the peptic ulcer perforation is only operative that the and the preoperatively we kept the NVM patients and
so in your study, hello,
analgesic, sorry, IV and pantoprazole operative.
In your study, what was?
Hello. Yes, sir.
Hello. In your study, post-operatively,
yes,
did any patient leak? Was there any leak in any patient? 50 patients.
Sir, in 50 out of 50%, the 5 patient had a history of leak.
Leak. Peptic leak.
Yes, sir. The 5 patients.
So how were they managed?
Sir, we managed by re-laparotomy.
So what you did in re-laparotomy in the 5 patients?
Sir, we detect the side of the leak and we close the site.
Are you sure you closed the site? Are you sure that this was done in all the 5 patients which leaked? Hello. 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 Can you hear me? Hello, can you hear me?
No, sir, not all the 5 patients.
I can't hear you. Actually, you are not audible.
Hello.
What you did in the 5 patients which leaked?
Am I audible? Hello.
Hello. What did you do for the 5 patients which had a peptic leak?
Hello. Sir. Yes, sir.
What did you do?
Hello. And so the time is up for Dr. Forum.
So is anybody ready?
Dr. Manohar, are you ready now?
Yes, ma'am, I am ready.
Okay. Start screen.
Okay, Manohar, you share your screen.
If you cannot, then let me know. I'll
Forum,
try.
you close your sharing the screen.
Yes, ma'am.
Forum, you close your share screen. Forum.
Dr. Forum. Okay, so stop. Manohar, you can start.
Yes, ma'am.
I think everyone should mute. There is some problem. Everyone should mute.
Sir, I have muted all the participants except the
Hello.
faculty and the.
Yes. I think that will decrease the sounds which are coming actually. Yes, anyone else is ready,
Okay.
so we can start with the Manohar,
Okay.
Bhushan or Pratik. Anyone is ready?
Yes.
No, there is an issue.
Yes, sir. I am ready. Can I present?
Yeah.
You are what? Who you are, Pratik or Roshan?
Yes, ma'am. Pratik, sir.
Okay, so start Pratik. What is your topic?
I'll just screen my share.
Okay, Pratik, start without wasting time.
Hello.
Pratik, can you hear me? Can you hear me, Pratik?
Hello.
Yeah, please start.
Yes.
Audible.
Yes, sir. Sir, my paper. Yes, sir. Yes, sir. Hello.
Yeah,
Okay.
start.
Okay, sir. My paper presentation is on a prospective study of management and post-operative. Okay, sir. Is on a prospective study of management and post-operative complications of breast pathology in females. In introduction, in India, 1 in 8 women will develop breast cancer. 1 in 35 women will die from breast cancer, and 31% of all cancers in women. Breast pathology is one of the most common ailments all over the world. It includes a wide spectrum of disease. In breast pathology, there is two mainly entity: benign breast pathology and malignant breast pathology. In the benign pathology, non-proliferative changes and proliferative changes. In non-proliferative changes, there is a fibroadenoma and fibrocystic changes. In proliferative breast disease, epithelial hyperplasia, sclerosing adenosis, radical scar, and intraductal papilloma. In malignant breast pathology, in situ carcinoma, there is two type: ductal and lobular carcinoma in situ. And in invasive carcinoma, ductal invasive carcinoma, and lobular invasive carcinoma. My aims and objectives of study is to study management of breast pathology in females and to study postoperative complication in breast pathology in female in PDU Medical College, and to prevent the morbidity by early detection of malignant breast pathology and early management of that pathology, and to prevent the postoperative complication in operative intervention by various measures. Materials and methods is the study design is prospective study for 2 years of duration. After obtaining institutional ethical committee approval and written informed consent, 50 females between the age of 89 and 65 years having breast pathology enrolled in this prospective study, which was conducted in female patients with different breast pathology admitted to surgery department in PDU Medical College and Civil Hospital Rajkot. All the patients with different breast pathology were put under study. Their clinical and demographic data was collected. Patients history was taken regarding duration of breast pathology, progression and size association complaints like pain, swelling, lump, social status, age, residence, discharge from nipple, retraction of nipple, and loss of weight. General and local examination was done. The information regarding the management of the patient and type of operation was collected. Then patient was followed up for post-operative complication like recurrence, wound infection, and wound disease and lymphedema. My inclusion criteria is all females patient between age of 18 and 18 to 65 years are included, and all female patients who are giving consent for prospective study. Exclusion criteria are all patients below age of 18 years and above 65 years are excluded. In results, observation and results, my age-wise distribution, there is more benign pathology seen in lower age groups like 18 to 25 and 26 to 35-year-old male, female, and malignant lesion are seen on increasing age like 46 years to 65 years age. In management, I'll collect data that most common operative procedure was done in our study was excision followed by modified radical mastectomy and then incision drain and drainage. Head field operation was done in only one patient. In postoperative complication, there is only 3 patients having a wound infection, others 43 patients having a non-complication. In discussion, present study comprises of total 50 patients who were properly examined, investigated with clinical examination of breast lump, cytology of lump, and imaging and PDMC all underwent appropriate operative procedures. In our study, 23 46%, 23 patients
Thank you
were
for the presentation.
operated for excision and
Sir, you can proceed.
Time up. Vinit, you can ask.
Yes, yes. So, Pratik, your time is up. Hello, Pratik. Dr. Pratik, can you hear me? Dr. Pratik. Dr. Pratik, can you hear me? Dr. Pratik, can you hear me?
I think we have lost him.
We have lost this. Actually, he was not audible also, but anyway, if we can ask 1 or 2 questions and then proceed to the next person if he comes online again.
Hello, sir.
Hello, Pratik, are you there?
Sir. Yes, sir.
Yes, yes. So your topic is management of the complications of breast pathology. So
Yes, sir.
what management you did? Like, you have not talked much about the management. You talked more about other things like these are the complications. But what did you do for seroma? What did you do for the other complications?
For seroma, we'll do for drain placement if lesion is larger. And
what you did in your patients in this series? I am not asking general word.
In my series, sir, I'll observe that there is a seroma formation. So in future, sir, we will prevent this complication by these measures.
Which measures will you take to prevent seroma formation?
In intraop HCV hemostasis and if there is a big excision, then drain placement for.
We keep drain in all the patients. How will you reduce the seroma formation? Or rather than lymphatic leak?
For that reason, lymphedema, post-operative physiotherapy will done for that.
Okay, time's up now. Manohar, sir, can we go with the next participant?
Yes, yes. We can
Yes, sir. I'm here, Dr.
Manohar,
Manohar.
if you're ready, can you please start screen sharing?
Yes, ma'am. Just 1 minute.
Dr. Manohar, can you start, please?
हाँ सर. Hello, sir.
Yes, yes. Start your presentation.
सर
Manohar, I have shared your presentation.
शेयरिंग चालू है इसलिए नहीं कर सकते. Please close the already screen sharing.
Manohar, you can share.
Just 1 minute. हाँ ma'am.
Okay, start.
Good morning, ma'am. Myself, Manohar Kadam, R3 surgery. I am presenting comparative study between Apache second score and Ranson's system in predicting the severity of acute pancreatitis. Introduction. Acute pancreatitis is a common disease with wide clinical variation and its incidence is increasing. The average mortality rate, severe acute pancreatitis approach 2 to 10%. Severe acute pancreatitis develops is about 25% patient with acute pancreatitis. 50% of death occur within the first week of the attack, mostly from the modes. The formation of infected pancreatitis, necrosis of fluid collection occurs usually in second week. The factor which cause death in most of the patient with acute pancreatitis seems to be related specifically to multiple organ dysfunction syndrome, and this death occur for 40 to 60% in hospital death in all age group. Aims and objective of my study are comparative study between Ranson's score and Apache second score in prognosis of acute pancreatitis. The study methodology type of study is a comparative study. Study duration is 2 years and site of study PDUC in Hospital Rajkot. Study design after the approval of the study protocol by institutional committee. Acute pancreatitis will be classified as alcohol related when patient reported as regular higher intake of alcohol or alcoholic binge directly before the onset of the disease and no sign possible other cause will be found like gallstone pancreatitis. An outcome will be defined as severe if associated with organ failure or local complication, whether or not the patient admitted to ICU. Organ failure will be estimated if one or more of the following factor will be present, such as shock, BP, less than 200, GI bleeding, and additional USG will be performed routinely at the admission and second site. All patients will be treated with standard therapy, nasogastric aspiration, proton pump inhibitor, total parenteral nutrition, analgesic, and antibiotics. Inclusion criteria: all patients above the age of 14 years with acute pancreatitis, all patients who giving the consent for the study. And exclusion criteria: all patients below the age of 14 years and acute pancreatitis, all patients with chronic pancreatitis and necrotizing pancreatitis are excluded from the study. Results: there are 50 patients, male was 37 and female was 13. In 50 patients, 22 pancreatitis was alcoholic and 20 pancreatitis was biliary, 8 pancreatitis was idiopathic. Multi-organ failure was seen in 3 patients. Respiratory complication are in 1 patient. Renal complication and local complication was seen in 1 patient. Then Ransom scoring system, score less than 3, 3 to 4, and 5 to 6, more than 6. Less than 3, there is a frequency of 45 patient. 3 to 4, the frequency of 5, and 5 to 6 nil, more than 6 nil. Total patient was 50. Apache scoring system 0 to 5, there was 36 patient in 0 to 5 score. 5 to 10 score, there was 9 patient, and 11 to 15, there was 5 patient. More than 15, no, there was no patient. Performa includes name, age, sex, ward registration number, date of admission, date of discharge, complaints,
Skip
abdominal.
skip pro forma. Next.
Discussion. The optimal management of acute pancreatitis include the acute early prediction of the disease severity. The aims of these thesis were to investigate early severe classification, complication, and outcome in acute pancreatitis with special regard to the patient developing the severe form of the disease. The result of the study, to early risk factor of the death were identified, increasing the age and hypotension at the admission. The death were at a high extent related to the multi-organ failure, multi-organ dysfunction. Early recurrence after the biliary acute pancreatitis was common. A model for early prediction of the severity in acute pancreatitis with artificial neural network was developed, identified 6 risk factors. Severe acute pancreatitis usually declared itself shortly after the onset of the symptoms, and delayed progression from the mild to severe disease is uncommon. Assessment of the severity of
For the participant for presenting, sir, you can proceed with questions.
Okay, Manohar, Dr. Manohar. So what was your conclusion? Like, which is better then? Is it Apache or is it the Ransom scoring system?
Sir, Ransom scoring system is better than Apache, but the specificity of Apache system.
Please speak loudly. I cannot hear you.
Sir.
Speak loudly.
Ransom scoring system is better than Apache system, but the specificity of Apache system is higher than the Ransom system.
How it is better? That is what I'm asking. Like, is it easy to use, and how it is better? Like,
So in a ransom scoring system, the parameters we include that are easy to evaluate the patient than the Apache system.
and as far as Apache is concerned, like, when did you analyze the Apache, and when you did, like, suppose a patient comes to you with acute pancreatitis, so what were when did you use these two systems, like the timing of the?
Sir, at admission and after 48 hours, Ransom's
Yes, Ransom,
scoring,
it is clear. What about Apache? When did you use it?
sir, both parameters are sometimes matching. So in severe such as multi-organ failure, patient with respiratory complications and renal dysfunction, we use these parameters.
So what did you conclude? Like, okay, this Ransom, what was your conclusion? One, how many patients of Apache and how many patients of Ransom scoring system? Like, you concluded that, okay, fine, this is this, if this comes, yes, these many patients had mortality or they were in a very bad state, and this was the score, and this is the. So what was your conclusion as far as both these scoring systems are concerned in your study?
Sir, Ransom system is very handy rather than Apache.
Yes, sir. What was the like, the, like, if the Ransom score is, let's say, 5, so what was your conclusion? You get my point? Are they really like, suppose if initially the Ransom score is, let's say, 8, so was it correlating with the data which is from other like studies, that yes, if there is AIDS, there is a high chance of mortality or something like that? Was it correlating with your study?
So time is up now. Maybe he can answer the last question.
Yes, okay, it's all right.
The last participant from the session 1, Dr. Roshan, are you there? I'm not able to see him in the list of participants. Dr. Roshan? I think he is not there.
We can start session 2.
We'll conclude session 1 here. We can start with the
Gunwan
session.
was not able to join because of net problem. He called me again. Okay, we can switch over to session 2.
Yes, sir. Faculty for the session 2 will be Dr. Jatin Bhatt sir and Dr. Jayesh Parekh sir. I'll unmute them. And the first participant is Dr. Ashwini Modi. Ashwini, are you ready with your presentation?
Yes, ma'am. Good morning, ma'am. Hello.
Hello. You can start screen sharing.
Hello. Yes, ma'am.
Hello, Dr. Ashwini.
Yes, ma'am. Yes, sir. Sharing my screen in a minute.
Okay. Dr. Jatin bhai, good morning.
Hello, good morning, Jayesh. Am I audible?
Good morning. You are audible. Ashwini, both of us.
Yes, sir.
Dr. Ashwini.
Yes, sir. Give me a minute. I'm just sharing my screen.
Okay, okay.
Jayesh, how are you?
Fine, fine. Nehal bhai, good morning. Dr. Nehal bhai. You have not unmute.
Okay, I would like to tell certain things to the participants. Number one is be careful about your timing. So you have to finish your presentation within 6 minutes. And second thing is regarding we want more discussion and conclusion. So after telling brief about your study, directly switch over to the discussion and conclusion. So we can have some questions and we can have some discussion.
Jatin, you can close it anytime and then start your questions anytime.
Okay,
Ashwini, if you are having issues, maybe I can try to share your presentation.
1 minute, ma'am. It's ma'am, is it I have shared it.
I'll try. Wait.
Okay, ma'am.
Julie, you start sharing.
I'm just trying that only.
Ma'am, I have opened it. Is it seen over it?
Yeah, it is seen.
Okay. Good morning. Good morning, everyone. My presentation is on role of touch imprint cytology in diagnosis of breast lump under the guidance of Dr. A.M. Rajaguru, sir. Introduction. Breast cancer is the most common cancer among the women worldwide as well as in Indian women in urban areas. While cervical cancer is the still most common site for the malignancy in rural areas. The projected number of cases of breast cancer in India in the year 2020 is 1,79,790. This will constitute about 10% of all cancers. Most of the women present with the complaint of breast lump, tissue sampling is mostly done by FNAC or a true cut biopsy. Touch imprint cytology of true cut biopsy specimen is a novel technique which aids in the rapid diagnosis of breast lumps from the true cut biopsy specimen. No added any morbidity or to the patient in it, as it does not require any additional procedure. At the same time, preserving the core tissue for the histopathological examination and ER/PR HER2 status receptor status assessment at a minimal cost. My aims and objective for the study is to compare the ability of touch imprint cytology to correctly predict the diagnosis of lesion when compared with the histopathological examination of true cut biopsy of breast lump. And second is to compare the sensitivity and specificity of touch imprint cytology with the histopathology of a true cut biopsy of breast lump. My study type was cross-sectional correlational study. My sample was 50 patients presented with the breast lump in undergoing true cut biopsy during the study period. Inclusion criteria was woman in age group of 15 to 75 years presenting with the breast lump and patient who give consent for a same. The excluding inconclusive true cut biopsy and touch imprint cytology results and patient who do not give consent for the same. All collected data was studied population analyzed to find out sensitivity, specificity, and positive predictive value, negative predictive value, as well as accuracy of touch imprint cytology. In procedure, first we give anesthesia to the 0.5% lignocaine with adrenaline at a part where the breast lump is present with the painting draping with the povidone iodine. After that, 14 gauge of true cut needle is used to take a biopsy, and the biopsy specimen is then prepared on the glass slide and transfixed with the isopropyl alcohol, and later on it is sent to the cytological examination. And another piece which is taken from the same true cut biopsy is sent to the for the histopathological examination in formalin solution. Here I have shown the pictures. First is local anesthesia I am giving, then is incision over the lump, then true cut biopsy firing for the specimen, then preparation of TIC slides, then fixation of slide, and the two specimen, one is in jar is for the TIC and one is in the one is for the HP examination, and then for the cytopathological examination. Results of my study was in sample characteristic. Most common age group I found it for the breast lump in population is 41 between the 41 to 50 years, which is 28% of total studied people. Mean age I found is 48 years. Most common age group having breast malignancy had age between the 66 to 75 years, which is 29% of my study group. Among them, postmenopausal are 32 females, which is 64%, and premenopausal are 18 females, which is 36% of my study group. Now the comparing true cut biopsy results with the histopathology, considering HP is ideal method. Out of 19 benign cases as per HP, 18 were correctly found benign and one false positive malignant finding on touch imprint cytology. Whereas out of 31 malignant cases as per HP, 29 were correctly found malignant with the two false negative benign findings on the touch imprint cytology. So concluding that with compared to HP, sensitivity of touch imprint cytology, I found 93.55%, with specificity 94.74%. PPV of 96.67%, whereas negative predictive value is 90%, with overall accuracy was 94% of touch imprint cytology. So, breast cancer is among the most common cancer in women worldwide, as well as in Indian urban areas, with the leading cause of cancer-related death. It has been proved that various studies that early diagnosis of breast malignancy favorably affects the prognosis. Among the case studies, 62% of female came out with the malignancy positive, possibly due to our institution being tertiary referral hospital. Among this, many patients were needed locally advanced carcinoma breast needed a neoadjuvant and chemotherapy. So, touch imprint cytology of true cut biopsy specimen as a diagnostic investigation in breast lump has shown sensitivity of 93.55, specificity of 94.74, positive predictive value of 96.67, and negative predictive value of 90% with overall accuracy 94%. It is helpful to get the early diagnosis and give it early treatment. So, in conclusion, touch imprint cytology of core needle biopsy is a rapid, reliable, and accurate method for early cytological diagnosis of symptomatic breast lesion. It's a quick result help doctor to deciding for the surgical management and pre-operative neoadjuvant chemoradiotherapy. It can also be helpful to reduce patients' anxiety in waiting for the histopathological report, which generally comes between 5 to 7 days, and increase in diagnostic performance. To conclude, touch imprint cytology of core needle biopsy is a sensitive method for detecting malignancy in breast tumor. Thank you.
Ashwini,
Yes,
Dr.
sir.
Ashwini,
Yes, sir.
you have compared the touch imprint cytology with the biopsy.
Histopathological biopsy.
Histopathology biopsy. Have you compared it with the FNSE or any literature available?
Sorry, sir.
Have you compared your study with the fine needle aspiration cytology?
No, sir. haven't come aspiration cytology because I have taken sample from true cut only. Among the single true cut specimen, one of it I sent for the touch imprint cytology, and one of the same true cut specimen I have taken sent for the histopathological examination. So I have seen that how earlier the true cut specimen of TIC is giving result, and with how it is helpful to give a rapid diagnosis and treatment for the patient. How it is beneficial from taken that single true cut specimen. So that same specimen is going for HP also, and that is how I am comparing the in this study.
Very good. So next is, do you know the meaning of sensitivity and specificity?
Sir, sensitivity is how it is more reliable technique, and specificity is how true positive is present and how true negative are there. How specific results we can get.
You are confusing. Just go and read it again. What is sensitivity and specificity? Dr. Jatin Bhai?
Yeah,
Sorry,
Ashwini,
sir.
Ashwini, have
Yes,
you
sir.
compared your study with any other study?
Yes, sir. I have compared it with many other studies.
And
One is
what
Shiv
was the
Prasad.
conclusion?
Sir, in many studies, it is similar conclusion. There is similar conclusion that in one of the Shiv Prasad, Dr. Shiv Prasad have studied same in around 2014. He has also concluded that its sensitivity is higher, around 94%, specificity 92%, and approx accuracy of 90%.
And
Sorry, sir.
what would be about sample size in both study?
In that sample size was around 60 patient he has taken, and in one other study, I don't remember, Dr. Calvin did same study in 10 years back, approx 10 years back. He has taken 100 patients in that year. And he did he also did the same study, and he has also same finding around 90% of accuracy and 94 to 92% of sensitivity specificity of TIC taken from
Okay.
same true cut batch.
Okay. Last question. Can we apply TIC in other pathology? Any other pathology
Yes,
where
sir.
it would
Yes,
be more
sir.
helpful?
Yes, sir. It is in lymph nodes and spleen, and in any intraop. We can also use this in intraop also. Like if we are removing the spleen or if we are removing any lymph nodes or something, and we can take immediate imprint also from the specimen, and we can get the result intraop even and immediate even from any other samples also.
Anything about
From any
pancreatic
other samples.
malignancy?
Sorry.
Pancreatic malignancy.
Pancreatic malignancy. I'm not sure about it, sir.
Okay, Chesh.
Yeah, now we go to the next candidate. Thank you, Ashwini.
Oh, thank you, sir.
Next is Jhansi Darji.
Yes, sir.
Miss Jhansi, are you ready?
Hello.
Hello.
Hello. Hello.
You are audible.
Hello.
Yes, Jhansi, you are audible.
Yes, sir. My slides are visible, sir.
Yeah, your slides is visible.
Should I start? Should I start?
Go
Sir?
PowerPoint presentation. Yes, very good. Very good.
Okay, sir. Should I start? Hello.
Yeah, Jhansi, start, please.
Okay,
yes,
sir.
Jhansi.
Yes, sir. Good morning, everyone. Myself, Dr. Jhansi Dalji. I'm from BJ Medical College, and I'm presenting the paper of role of endoscopic procedure in case of CBD calculus, and under guidance of Dr. Neena Shah. Introduction. Choledocholithiasis is more common. Choledocholithiasis or common bile duct stones can be classified into primary and secondary. Primary stones arises de novo in the bile duct, and secondary stone passed from the gallbladder. Choledocholithiasis may appear in the following 5 ways. First is asymptomatic, then it can be present as a biliary colic or jaundice, or cholangitis, and pancreatitis. The last 4 may appear in combination. If stones obstruct the common bile duct and become infected, then acute cholangitis will occur. Classical triad of fever with chills, pain in the right hypochondriac region, and jaundice leads to suspicion of the choledocholithiasis. Now the endoscopic procedure, endoscopic retrograde cholangopancreatography, along with that sphincterotomy and stone extraction procedure like balloon or basket is efficacious in removing the CBD calculus. ERCP has largely replaced open or laparoscopic surgeries. It is diagnostic as well as therapeutic for the management of the choledocholithiasis. And complications associated with the ERCP are pancreatitis, which is most common, then hemorrhage, perforation, and cholangitis. Aim of the study to know the efficacy of the ERCP in case of the choledocholithiasis, to know the outcome of the patients which are undergoing the ERCP in terms of morbidity and mortality, to know the complications associated with the procedure, including pancreatitis. Methods. This is prospective study of 25 cases of common bile duct stones admitted in the Civil Hospital Ahmedabad during the study period of May 2018 to October 2020. They underwent ERCP and data were collected on the basis of outcomes of the patients. ERCP along with sphincterotomy and stone extraction was attempted in all patients. Results: out of 25 patients, 14, that is 56% were male and 11, that is 44% were female. Out of 25 patients, 11, that is 44% patients were having single stone and rest 14, that is 56% had multiple stones. The average size of CBD calculus is 11.3 mm and largest is 22 mm. The success of ERCP depends on the status of CBD, number of stones, diameter of the CBD, and condition of the patient. Those patients with incomplete stone removal had multiple stones, and those patients underwent CBD those patients who are having incomplete removal of stones underwent CBD exploration and the removal of stones. Pancreatitis developed in 2 patients, that is 8%, and only 1 patient developed sepsis, and none of them developed hemorrhage and perforation. These are the chart we suggest in finding of ERCP. 2 patients out of 25 having difficult cannulation, and 20 patients are successful removal of stones are there, and 21 patients sphincterotomy was done. In all 25 patients, CBD stenting was done, and in 5 patients there is incomplete extraction of the stones. These are the chart which showing the complications. As I earlier mentioned, pancreatitis in 2 patients, sepsis in 1 patient, that is 4%. And in my study, there was no hemorrhage and perforation. Discussion. CBD stones most commonly occur in female, but due to small population, differences cannot be appreciated. Out of 25 patients who underwent ERCP, stones were successfully removed in 20 patients, that is 80%, and 5%, that is 20% patients, there was incomplete removal of the stone. Sphincterotomy done in 21 patients, that is 84%, and stenting was done in almost all patients. Those patients who is having multiple stones tend to have retained stones during the first ERCP attempt. Summary. ERCP is highly specialized procedure which requires a lots of skills and experience, and the procedure is safe and associated with very low rate of risk when performed from an expertise. Thank you, sir.
Hello, Jhansi.
Yes, sir.
So why have you studied this case ERCP? Do you want to evaluate ERCP as a therapeutic procedure efficacy? What is the idea behind selecting such topic?
Sir, ERCP is therapeutic as well as diagnostic. But sir, previously ERCP was not that much used. Previously, we used to go for the open surgeries or laparoscopic surgeries. But ERCP is decreasing the morbidity as well as the mortality. And also it can be used in the patients.
My idea is ERCP is already established thing. It is not a newer thing.
Yes, sir.
So
I don't get your question.
I think Jayesh is disconnected. Zonsi, can you hear me?
Yes, sir.
Oh, okay. So till Jayesh come back, can you answer that? What are the cases where you would like to directly go for the surgery rather than attempting ERCP?
Sir, if the patient is having large stone and multiple stones, And sir,
Large stone you have gone for
so
the
more than
ERCP
sir,
up
if
to,
sir, if
up
it is
to
more
the,
than 2 centimeter.
okay. Any other criteria?
And sir, if I also want to go for the cholecystectomy simultaneously, and
Okay. Now tell me, you said that in 5 cases there was incomplete removal of the stone. How
yes,
did you
sir.
came to that? And then how you have managed that cases?
Sir, those patients underwent. Hello.
Yes, go ahead.
Sir, those patients underwent CBD exploration, and sir, choledochoduodenostomy was done.
And at what time? Immediately?
Yes, sir. Sir, in few patients it is immediately, and sir, those who are having severe complications like pancreatitis or sepsis, sir, those patients were not posted immediately.
Okay. Jash, you can continue.
Yeah, no more questions. Once you can sign out. Next one is
Divyam.
Thank you, sir.
Next one is Dr. Divyam Goel.
Divyam, please start your screen sharing. Divyam? Divyam, are you there?
Yes, I'm here. Am I audible?
Yes, you are audible.
Is my screen visible?
Yes, Divyam, continue.
Good morning, everybody. I'm presenting my paper on emergency stoma, its risk factors, complications, and their severity.
Divyam, little bit louder.
Am I audible now, sir?
Yeah, but low voice.
Okay. My design of my study is a prospective clinical study. It was done under the guidance of Professor Jatin Bhatt in the Department of General Surgery, PDU Medical College and Civil Hospital, Rajkot. So a little bit about intestinal diversion. Though it is a life-saving procedure, it is associated with a significant number of early and late complications. And the factors that affect the type and frequency of complications are though known but very poorly understood. And those stoma created in emergency have higher complication rate as compared to the elective stoma. So we designed the study with the aims to identify the incidence of stoma related complications, to identify the risk factors that are associated with stoma related complications, and to devise a scoring system for quantification of severity of complications as well as the risk factors that lead to development of these complications. We took 100 patients that underwent emergency laparotomy with stoma formation, and these patients were followed up over a period of 3 months for both early as well as late complications. Both the risk factors and the severity of complications were graded, and the scores were calculated. So correlation of was studied between the risk factors and the complications, and it was seen if whether the risk factors are associated with the complications or not. And based on this, we tried to develop a quantification score for both the risk factors as well as complications. So our inclusion criteria was the patients more than 12 years of age who were undergoing emergency stoma formation. And our exclusion criteria was the patients who had uncontrolled metabolic disease and patients who had undergone urostomies or jejunostomies. So in results and discussion, first out of total 100 patients, there were 46 patients who had undergone ileostomy, while there were 54 patients who had undergone colostomy. Out of these 46 ileostomy patients, only 8 patients were there who did not had any complications, while 38 patients of ileostomy had some had complication in some form or the other. While out of 54 patients undergoing colostomy, only 30 patients had complications, while 24 patients did not develop any complications. And among the complications, the most common stoma-related complications that ostomates had faced was leakage from the stoma bag, periostomal dermatitis, and pain at the stoma site, being 55%, 41%, and 54%. Other less frequently uh, experienced complications were bleeding from stoma site, stomal necrosis, stomal stenosis, retraction of stoma, mucocutaneous separation, and parastomal herniation. So the most frequent complications were leakage, dermatitis, and pain. We have shown the grading of these complications. If grading was given to every complication, I have shown only the 3 complications that were the most frequent. Here we can see that 55 patients had experienced leakage. Out of those 55 patients, only 11 patients had significant leakage, that is 1 to 2 times per day. Otherwise, rest 44 patients had leakage, that is 1 or twice in a month or a week. Similarly, in dermatitis also, 41 patients experienced peristomal dermatitis, of which only 20% patient had moderate to severe dermatitis, while rest 21% had only mild dermatitis. In pain also, 54% patient experienced peristomal pain, but only 3 patients were there who had experienced severe pain at the stomal site. So according to this grading system, this chart that shows the grading system, we had devised a stoma complication severity score. And on the basis of this score, we have given the index that is good, satisfactory, moderate, poor, or very poor. According to this index, 32 patients who had not developed any complications had a good SCSS score, while 21 patients had a satisfactory score who had score between 1 or 2. The patients having score between 3 or 5 had moderate complication severity score, while 17% patient had poor or very poor score. So this was regarding the complications. Now coming to the risk factors that lead to development of these complications, these are the previously known factors or the factors that we believe would be affecting the complications. So gender, and these were the risk factors that were taken into consideration, and it was found that male gender was associated with the leakage from the stomal bag, and income less than 2 lakh per annum was associated more associated with leakage and dermatitis. Preoperative education and stromal site marking, if they were not done preoperatively, then it was associated with leakage and dermatitis. The indication of stoma, in indication of stoma, malignancy, inflammatory bowel disease, and ischemic bowel disease, these were found to be more associated with necrosis, stenosis, and mucocutaneous separation. Type of stoma, among type of stoma, the end stoma was found to be more commonly associated with necrosis, stenosis, retraction, and mucocutaneous separation. The
Time up for
consistency.
presentation. Sir, you can
Conclude,
proceed with
Divyam,
questions.
you conclude your presentation.
Okay, I'll just take 1 minute to conclude. So
Yeah.
this according on basis of this risk factor score, the significant risk factors were included in a stoma risk factor score, and on basis of this, we have calculated the cumulative scores. And on comparing the stoma risk factor score with correlating it with the complication severity score, we found that the higher the score, the more is the complication severity score. So there was a significant correlation. In conclusion, I would like to summarize that the leakage, peristomal dermatitis, and pain at the stoma site are the most frequent complications, followed by retraction, stenosis, necrosis, and mucocutaneous separation. While male gender, low income, lack of preoperative education, and preoperative stoma site marking, liquid consistency of effluent are associated with dermal complications and stoma, and indications of stoma formation like malignancy, IBD, and bowel ischemia are associated with necrosis, stenosis, retraction, and mucocutaneous separation. And the two tools that we have tried to form here, like a stoma risk factor score and stoma complications severity score, are simple and reliable measures for quantification of risk and severity of stoma related complications.
Okay, Divyam. How will you prevent peristromal dermatitis?
Sir, as the most common risk factors associated with the peristromal dermatitis we have found here are male gender, income, preoperative
How will you,
education.
what precautions or how will you construct the stoma to prevent peristromal dermatitis?
Sir, to prevent peristromal dermatitis, we would like to side the stoma away from the bony markings. And in case of patients who are obese, we would like to make a stoma on more superior position, as if on making stoma
Any
on
other
dependent
technique?
position.
Any other technique? Do you know Brooks ileostomy? What is Brooks ileostomy? Okay, Jatin bhai.
No, sir.
Time is up now.
Okay, we can ask with one question and then we can conclude.
Okay.
Divyam, can you tell us how this study is going to help future management of stoma?
Yes, sir. Sir, we can
Briefly, you have to answer briefly.
These scores are based on the clinical analysis only, and if the stoma risk factor scores are higher, then the modified risk factors can be taken into consideration, like the income and operative education and stoma site marking, which can significantly reduce the most common complications like leakage and dermatitis.
Okay, we can conclude this. And now next participant, Jayesh.
Okay,
Next is Madhav Santoki.
Hello, good morning, sir.
Good morning.
Am I audible, sir?
Yeah, you are audible.
Madhav, you can share your screen.
Yes, ma'am. Good morning, sir.
Good morning.
I am presenting a paper on blunt abdominal trauma, conservative versus operative management, retrospective study. So abstract of my study, blunt abdominal trauma is the common and it is associated with the high morbidity and mortality. Timely diagnosis and early intervention is key to successful management. Aim and objective of my study is to done to analyze the patient profile and their management. Method: 25 patients who were admitted in Civil Hospital Ahmedabad studied retrospectively. Age and gender distribution, mode of injury, clinical presentation, solid organ injured, investigations, hospital stay, and conservative versus operative management, and their outcome were studied. Result were out of 25 patients, 22 were male and 3 were female. 80% patients are from 20 to 40 years of age group, with the mean age of 26 years. Majority are due to road traffic accident, and abdominal pain is the most common presentation. Liver and spleen are the most common solid organ which are involved. 80% patients are managed conservatively, and remaining undergone operative intervention. Average length of hospital stay in conservatively managed patient were 15 days, and patients who were managed operatively having a hospital stay of around 18 days. Conclusion of my study: conservative management is a safer and reliable mode of management in the hemodynamically stable blunt abdominal trauma patients. So starting with introduction, isolated blunt abdominal trauma is usually a very rare, and most of the time it is associated with the other injuries such as head injury, chest trauma, long bone fractures, and extremity injuries. In spite of the best techniques and advance in the diagnostic and supportive care, morbidity and mortality remains at large. The reason for this could be due to interval between the trauma and hospitalization, delay in the diagnosis, inadequate and the lack of appropriate surgical treatment, post-operative complications, associated trauma, especially to head, thorax, and extremities. Other factors which influence outcome of the solid organ injuries due to blunt abdominal trauma include hemodynamic instability, associated injuries to the other body parts, and of course Glasgow coma score. Method study was carried out in the civil hospital Ahmedabad to study age population at risk, common cause of blunt abdominal trauma, various mode of presentation, diagnostic modalities, and management of the blunt abdominal trauma. 25 cases of blunt abdominal trauma admitted during the period of January 2020 to the July 2020 in civil hospital were studied. All patients are investigated with history, physical examination, routine blood investigation, and radiological imaging. Inclusion and exclusion criteria includes hemodynamically stable patients after initial resuscitation having a systolic blood pressure more than or equal to 90 millimeter of mercury, whereas patients with which are hemodynamically unstable, having a systolic blood pressure of less than 90 mm of mercury, despite of resuscitation. Patient with hemoperitoneum with solid organ injury in blunt abdominal trauma, whereas patient which are excluded are penetrating abdominal injuries, sir. Patient in the age group of 2 to 60 years of age with no any sex preference, and patient which are excluded are X-ray abdomen showing free gas under diaphragm, history of hollow viscous injury. Results of my study: majority of the patients are from the male gender. 22 were male and 3 were female. Majority of the patients having a mode of injury due to road traffic accident with include solid organ injuries in this patient are around 70%, followed by fall from the height around 10%. Assault include 10%, and other are industrial accidents. Latent period, it is a time between presentation of the patient to the hospital and the mode of injury, time of the injury. More than half patients were brought for the treatment within 5 to 6 hours of the injury, while 36% of the patients were brought for the treatment within 24 hours. 80% presented with complaint of pain abdomen, while 20% patient did not have any abdominal complaint at all. 80% patient were between the age of 20 to 40 years, and 60% patient were below the age of 20 years, and 4% below the 40 years. So comparing mortality and organ involvement, patient who were managed conservatively are in my study is 80%. Among them, 25% patient has mortality rate. So 15% patient having a good outcome with conservative treatment, and patient managed with operative intervention having a mortality rate of around 40%. Organ involvement showing majority are patient having liver and spleen involved in the blunt abdominal trauma. Other organs are adrenal, kidney, pancreas, and urinary bladder.
Time is up for presenting.
Discussion. In my study, 25% patient, 25 patient of blunt abdominal trauma were studied retrospectively, who were admitted to civil hospital Ahmedabad. Majority are from the male gender with the age group of 20 to 40 years. And the most common cause of the blunt abdominal trauma was road traffic accident. Diagnostic procedures should be limited to those examinations that have proven effective in the blunt abdominal trauma and should not delay in the laparotomy in an unstable patient. Utilization of this time to initiate resuscitative measures and to prepare for abdominal exploration is of much greater benefit to the patient.
Sir, time is up for presenting.
Madhav, can you go to the conclusion?
Yes, sir.
Show us last slide.
So conclusion from my studies, blunt abdominal trauma is a major cause of morbidity and mortality in young and economically productive age group. Road traffic accident is a major causative agent for blunt abdominal trauma. Availability of the emergency resuscitation and the trauma care services, especially near the roadside highway, helps in the lowering the mortality. With investigations like ultrasonography or CT scan, there is a paradigm shift in the management of the non-penetrating trauma abdomen from operative to non-operative mode. Conservative line of management is safe and effective in hemodynamically stable patient without any signs of peritonitis.
Okay, fine. Madhav, can you tell us that what solid organ have you included in your study?
Yeah, sir. Excluding sir, small bowel and large bowel, all the solid organs are included in the study, sir. Liver, spleen,
Does
pancreas.
pancreas and kidney were there in your study?
Yes, sir.
Okay, fine.
Okay, Madhav. Okay, Madhav.
Yes, sir.
One last
Yes, sir.
question. Can you came to any such conclusion? Can any particular methodology decrease the mortality in blunt abdominal injury? Any such finding or doing adopting such technique, it reduce mortality?
Sir, in patients whom we are giving trial for a conservative management for blunt abdominal trauma, we
Yes.
can ask patient to strict immobilization and complete bed rest and.
So out of conservative treatment, how many are saved or does not have to operate?
Sir, 20 patients are managed conservatively, from which 5 patients have mortality rate. So
without conversions or without operation?
Yes, sir. 75% is
okay.
Okay, last question, Jesh.
Yeah.
Madhav, can you tell us, this is a retrospective study. So can you tell us what are the advantages of retrospective study and what are the disadvantages?
Sir, from the retrospective study, we can we cannot, sir, include any.
Okay, we can move to the next participant.
Thank you, sir.
Next is Dr. Rahul.
Sir, Rahul. Next is
yes, sir.
Rahul.
Good morning, sir.
Good morning.
Madhav, please stop your screen sharing.
Okay.
Rahul, you can share screen now.
Yes, ma'am.
Good morning, Jayesh sir, Jatin sir. Rahul, please turn on your video along with the screen sharing so that the faculty can see you.
Yes, sir. Light.
Rahul, is there any issue with screen sharing?
Yes, ma'am.
Okay. I'll try to share the screen. I'll just try to share your paper.
Yes.
Okay.
Yes.
Is it visible to all?
Yes, it is visible.
Okay, Rahul, you can start now.
Yes, good morning to everyone and respected my teachers. My paper presentation on prospective comparative study between open Liechtenstein method versus hernioplasty versus laparoscopic TAPP, transabdominal preperitoneal hernia, inguinal hernia repair. Hello.
Yes, you continue.
In my introduction, the rapid changes that have been witnessed in an open approach of inguinal hernia surgeries, that prosthetic materials and laparoscopic surgeries have made a hernia surgery most interesting field of endeavor that demands renewed discipline and dedications. A variety of procedures are performed that can be termed as an ideal procedure, as each one is accompanied by a varied early and late complications, and the most significant being recurrence. My aims and objectives that to compare the outcome of both open and laparoscopic TAPP inguinal hernia repair of patient's duration of stay, postoperative pain, and other complications that occur between open inguinal hernia mesh repair and laparoscopic hernia repair, and to arrive at a conclusion. Materials and methods. The type of study is a non-randomized prospective study, and study duration of 2 years, and sample size is 15 cases of open inguinal hernioplasty versus 15 cases of laparoscopic transabdominal preperitoneal hernia repair. And the following of the parameters evaluated for both open and laparoscopic procedures, that patient selection, and for that patient selection, that age, sex, and male age, sex, and weight, and means body mass index, and in intraoperative and postoperative complications that we have followed up, and recurrence that we have followed up in our OPD after the postoperative postoperative complications. Inclusion and exclusion criteria. That inclusion criteria: patients with unilateral or bilateral inguinal hernia with reducible and non-obstructive, and all patients of age between 20 to 65 years, and are included in this in our study. And exclusion criteria is that all patients below the age of 20 years and above 65 years of inguinal hernia, and obstructed or strangulated hernias that are in exclusion of our study, and hernias other than inguinal hernias. Results. Results that we find the duration of hospital stay, that surgery we have done open inguinal hernioplasty of 50 patients, that mean duration of hospital stay is 1.9 days, and in our laparoscopic repair TAPP, that the mean duration of stay is 2.14 days. And postoperative postoperative complications, that in open hernioplasty, that local pain was 4% in all of the patients of 50 patient number of patient is 50, and in laparoscopic repair there is 3% of out of laparoscopic left TAPP patients that local pain was present. Total 7% of total patient local pain, and in scrotal edema is 11% in open inguinal hernioplasty, as of 4% in left tap, and wound infection is 9% in open inguinal hernioplasty, and 3% in laparoscopic repair, and mass infection 1% in hernioplasty, open inguinal hernioplasty, and nil in the laparoscopic hernia repair, and urinary retention was in open inguinal hernioplasty was 0%, and laparoscopic repair was 1%. So that in given in the postoperative complication is in graph. In the discussion, that in our study, minimum age with occurrence of hernia was at 21 years, and the eldest being 59 years, and all the patients in the study were men. And in the study that done, reference study was Dr. Udwadia Thimentan, at wound infection rates were significantly lower after laparoscopic techniques, that 1%, and then after the Liechtenstein inguinal mesh plasty 2.7%, and other open mesh repair that 2.4%. Incidence of inguinal hematoma was found to be significantly lower after the lap tap, about 30.1%. And after the open inguinal mesh plasty, that 16%, as well as with other open mesh techniques, that 14.3%. And in our study, that has comparable results with all above the above study regarding postoperative complications. And severe pain was complained in 6 cases of open inguinal mesh plasty, and 1 case of laparoscopic hernia repair, and while 7 cases that of left tap had mild pain. There were two recurrences noted in laparoscopic hernia group. There is one in open and one both open and hernia laparoscopic hernia repair. Okay. And conclusion is that a few recurrences were noted during the study period, and the recurrence rate were higher in the laparoscopic hernia repair group when compared to hernioplasty group. Repair of the inguinal hernia is one of the commonest operation performed by surgeons around the world, and the treatment of this common problems has seen an evolution from the pure tissue repairs to the prosthetic repairs and in conventional open approach to laparoscopic approach. However, there is still no agreement about which operation is preferable in a given situation, as complications are varied in both of the procedures. Also reported to cumulative recurrence rate varies widely from 1% in special centers to the more than 30% in the cited reviews. Okay, thank you.
Time is up for presenting.
Rahul.
Yes, sir.
Rahul.
Yes, sir.
This is your prospective study. All
Yes.
the TAPP was performed by the same surgeon or variety of or different surgeons?
Different surgeons.
Different surgeons. Okay. Second question: how they are using sterilize their laparoscopic instrument for TAPP? Is it how they are sterilizing?
Sterilization technique is that autoclaving that all that using.
So you had all laparoscopic instruments are autoclavable.
Yeah, no, except that optical fiber trocar that was not autoclavable.
Okay.
Yes, sir.
Because you are showing it is there is a lesson. Have you compared the cost factor of the open versus TAPP?
What's that?
Cost factor.
No, sir. In my study, that cost factor was not compared.
Is the mesh size is the same for the unilateral inguinal hernia versus TAPP mesh size?
Yes, sir. Yes, sir. Mesh size was same size.
Same mesh.
Yes, sir.
Are you using same mesh size for open hernia versus TAPP?
Yes, sir. Yes,
Because
sir.
TAPP
In both of
they
the
are
operative
recommended
procedure,
larger size of mesh. And last question: what is the recurrence rate? Because your study is the 2 years durations. What is recurrence rate in both?
Sir, 1% in both of the studies.
Okay.
Yes, sir.
Is your study sufficient enough to conclude anything? Your
not sir. That
your database, is it sufficient enough?
Sir,
okay.
in my study, I
over to Dr. Jatin Bhai.
Okay. Okay. Rahul, how you have randomized patients in your study? Does it was a randomized trial?
No, sir, non-randomized study.
So then, do you think your statistics and your results are at par with the randomized study, or it should be considered? What are the disadvantages of doing non-randomized study?
So time is up.
Rahul, do you understand the Dr. Jatin Bhatt's questions? Are you know what is randomized, what is non-randomized, what is cohort study, what is case control, what is prospective, what is retrospective?
Yes, sir.
So that is Dr. Jatin Bhatt is asking you, what are the disadvantages of the non-randomized trial? Okay, Jatin Bhai, anything else?
Okay, we can conclude. We can conclude.
Okay, who is the controlling PG masterclass name?
Sir, this is Julie, sir.
Julie, excellent conductions. Very good.
Thank
Can you unmute Dr. Nihal Naik before going to?
Yes, sir. Yes, sir. I've unmuted, sir.
Oh,
Jatin bhai,
Nihal
bolo.
Good morning. Good morning.
Good morning, Jayesh bhai. Very good morning.
Good morning, Nehal. How are you?
Very fine, Jatin.
Okay, chalo ત્યારે. Special thanks to Ninaben and Pankajભાઈ કે આવી રીતે આપણે મળવાનું થયું જયેશ અને નેહલ.
Yeah, thank you.
Okay, bye.
Okay, bye.
Good day.
Good day.
જયેશભાઈ તમે ક્યાંથી બોલો છો?
રિયલ વર્લ્ડમાંથી.
ગોવા છો કે શું જયેશ?
ના ઘરમાં છું. રિયલ વર્લ્ડ. આશિષભાઈ ગુડ મોર્નિંગ.
ગોવાના મૂળમાં.
Good morning, sir. Hitesh good morning.
Hitesh good morning. Ashit good morning.
Jatinbhai. Okay, fine. Chalo.
Ashit bhai.
Yes, sir.
Oh, good morning. We are signing out now. Okay. Thank you, Julie. Thank you.
Bye.
We'll conclude the session 2 and we'll start with the session 3. The faculties will be Dr. Hitesh Andaria sir and Dr. Asit Patel sir. And the first participant is Dr. Devang Kalatia. Dr. Devang? I'm not able to see him in the participants list. So we'll go with the next participant, Dr. Akriti.
Yes, I'll just share my screen.
Okay. Akriti, you can start your screen sharing.
Okay. Good morning, sir. Today I'll be presenting a...
I'm sorry for interrupting. Please make sure, Julie, please make sure all participants have their videos on, because we have made it a rule even on station 2, they have to turn their video on along with the screen sharing so that the faculty and the rest of the participants can look at the participant. Yes, please go ahead. Good morning, Hitesh sir. Good morning, Asit sir.
Good morning.
Good morning, sir. Today I'll be presenting a paper on a study of post-operative pyrexia in emergency laparotomy patients. I've conducted this study in our hospital itself in PDU Civil Hospital Rajkot under the guidance of Dr. Jignesh P. Dave sir for a duration of 2 years. The fever is basically, there's no specific temperature that has been that can be said to be considered as fever, but in most of the studies they have concluded that a morning temperature of 98.9 degree Fahrenheit and an evening temperature of more than 99.9 degree Fahrenheit to be considered as fever. So post-operative fever, it is seen in most of the studies that 14 to 91% of the patients after a surgical procedure are prone to get a post-operative fever, which in 48 up to 48 hours is generally because known as a benign fever, which is not generally because of any infection or anything, and can generally resolves on its own. But if it lasts up to 96 hours or occurs after 96 hours, we have to take in consideration to go ahead with special investigation to find out the cause and treat the patient, as this fever may be associated with the surgical outcome in the form of mortality and morbidity, and also increases the stay at the hospital and cost of treatment. So the aims and objectives of my study were to study the common cause of postoperative pyrexia in patients who have undergone emergency laparotomy, and to study the risk factors which are associated with the occurrence of postoperative pyrexia. So the material and methodology that I used were, it was a prospective observational study conducted over a period of October 2018 to October 2019. And it included all the patients of all ages and sex who developed fever after undergoing an emergency laparotomy. And I collected all the data of various patients to find out the different causes that resulted in postoperative pyrexia and the associated risk factors with it. And a follow-up of at least 1 month post-surgery was done. And all these patients before surgery were administered prophylactic antibiotics and were monitored up to 7 days for any fever spikes and complaints of fever. And post the occurrence of fever, we underwent with repeat investigations, all which included the all routine investigation and some of the specific investigation according to the day of occurrence of fever in order to, and the complaints of the patients in order to find the probable cause. And the sample size was 100 cases. So the few results found...
Do you have any inclusion criteria for this study?
Yes, in inclusion, sir, I included all the patients. that develop postoperative pyrexia after undergoing emergency laparotomy patients. In exclusion criteria, only the patients that presented to us with fever, sir, at the time of admission were excluded. Rest all the patients were included, sir.
Okay, go ahead.
For results and analysis, so the age distribution that we found that more than 30 years and the patient between 30 to 60 years and more than 60 years had more incidence of developing post-op pyrexia. So as the age was increasing, the trend of post-operative pyrexia and the fever spikes and the grade of pyrexia were also increasing. In sex distribution, it was more commonly seen in the male patients than in the female patients, which were 72 male patients presented with post-op pyrexia and 28 females. Then we compared we also took into account the presence of comorbidities. 17 patients each presented to us with diabetes and hypertension. Some of them were taking on regular medication, some were diagnosed at the time of admission itself and the medication started. And some of them presented with associate comorbidities were CVA, HIV, and asthma, which were relatively less incidents than the presence of diabetes and hypertension. And there were at least 5 patients which had overlapping comorbidities. And what I observed was that the patients who are having more number of overlapping comorbidities were more prone to developing post-operative pyrexia. Then in habits, I took into account 3 more common habits that we are seeing in this region of this area, that were smoking, tobacco chewing, and alcoholism. So 28 patients had the habit of smoking and 18 alcohol ingestion, and 21 had the habit of tobacco chewing. Then the category of surgery, we divided according to the classification, we divided it into clean, contaminated, and dirty. Most of the patients who presented to us, we found the wounds to be the category of surgery to be dirty, as there was presence of severe peritonitis, and such patients were 53, and they were more prone to developing fever than the other patients. And then the duration of
So
surgery.
these patients were not having fever preoperatively?
No, sir. They didn't present to us with fever preoperatively, and temperature was also recorded. They didn't have any complaints. And on recording the temperature also, we didn't find fever. Only then they were included in the studies.
Okay.
Then duration of surgery, as
what is the difference between contaminated and dirty?
So contaminated, if the viscous is opened and there's spillage, but not extensive amount, and it has been localized to a certain degree. But in dirty,
And what is the difference between clean contaminated and contaminated?
so clean is surgery like in which the viscous is not opened, like in cases
No,
of
clean contaminated and contaminated.
Okay, sir. Sir, in clean contaminated, either there's a iatrogenic opening of the viscous, or there's a viscous open with very minimal spillage, sir.
Okay.
Then the duration of the surgery, as the duration of the surgery increased, there was I noticed that there's a increase in the incidence of post-operative pyrexia. So if it was more than 1.5 hours, then there was more incidence of post-operative pyrexia after the surgery.
Time is up.
Based on the days of pyrexia, there was
You can go to the conclusion.
So I concluded that the most common cause of pyrexia that we noticed in our hospital was the surgical site infection, and the risk factors that came into being were the presence of comorbidities, increasing age of the patient, male sex, smoking, alcohol intake, and presence of anemia, with the increase in duration of surgery and presence of peritonitis. So to conclude, we should take into account the preoperative checkups and put more focus on them, so that we can analyze the significant risk factors that have been found in this study, and also similar factors have been found in other studies. So
Okay. Okay. Is it the same study title? Is your thesis also?
Yes, sir.
So it has been accepted?
Oh, yes, sir.
Thesis has been accepted by university? Yes or no?
Yes, sir.
Okay. Okay. ठीक है. हितेशભાઈ કે પૂછવું છે બીજું?
Did you consider use of antibiotic depending upon the system involved, or you have not considered?
No, sir. We have. We initially started with the prophylactic antibiotics, but
You haven't considered it in your discussion or conclusion. So
Uh,
we presume that this is without the use of antibiotics.
no, sir. I had mentioned that we are using prophylactic antibiotics in my.
Okay, but
It is not a prophylactic. Basically, it's a therapeutic. You must have
when
continued.
you have used the word dirty.
Yes, sir.
Yeah,
So
and
later,
you
found-
must have continued for more than 48 hours.
And what was the molecule chosen? No consideration.
Sir, once we found out that if we have after we have operated or we have got the counts of the patient, we have shifted the antibiotics.
Only depending upon counts you start antibiotics.
No, sir. After the patient complained of fever, we have run the
What are your protocols?
Sir, after
For
we have
different categories, which 4 categories you have described?
Sir, actually, we give Genta, Amica, and Metro to all the patients.
Irrespective of the surgery?
Yes, sir.
Irrespective of the surgery?
For surgery, we give these 3 antibiotics, sir.
Gentamicin, amicacin, both?
No, sir. Either gentamicin or
Okay,
amikamycin along with ceftriaxone and metronidazole, sir. This we
That
give
is a-
before the surgery, sir. After we have got the investigations or we have opened.
Regardless the type of surgery?
Yes, sir.
Regardless of the type of surgery, it may be soft tissue infection, because I think you must have included some soft tissue infection.
No, I have
Yeah, the laparotomy is there.
laparotomy is
Okay, okay.
emergency exploratory laparotomy.
Right.
And after the patient presented with fever, sir, if based on his complaints, if we are considering, and we have sent, if there's a pus, we have sent the pus CS, urine CS, and if it is a respiratory tract infection, sir, we have switched antibiotics and given different supportive management based on that to control the fever and
Okay.
better
ठीक है.
recovery of the patient, sir.
I think time is completed for her.
Yes, sir. Sir, Akriti, please stop your screen sharing. The next participant is Dr. Vimal Vora.
Yeah.
Dr. Vimal. Dr. Vimal.
If he's not there, you can.
Okay,
Take,
I'm not able
another.
to see him in the next is Dr. Ishan Patel. Dr. Ishan.
Yes.
You are there?
Yes, yes.
Okay. Please start screen sharing.
Yes.
And keep the video on.
Okay. Good morning, sir.
Very good morning.
Yes, sir. I am Ishan Patel, from third year from Department of IHBT. I will be presenting on plasmapheresis in neurological and other autoimmune disorders. Plasmapheresis, also known as therapeutic plasma exchange, it is the process in which whole blood from an individual is withdrawn and a component such as plasma is separated and retained. The remainder is returned to the patient, usually with some replacement fluid. It is the process in which whole blood from an individual, such as components such as plasma, is separated out. Okay, TPE is most commonly indicated in severe neurological and autoimmune disorders such as Guillain-Barré syndrome, myasthenia gravis, chronic inflammatory demyelinating polyneuropathy, polymyositis, and thrombotic thrombocytopenic purpura, dermatomyositis, etc.
So you are from medicine department?
No, sir, immunohematology.
Immunomet. Okay. Yeah, go ahead.
The separation of plasma from the blood's cellular elements can be achieved with centrifugation devices based on principle.
That's okay. That's okay. You can go to your methodology part.
In our prospective study,
Mm-hmm.
all plasma exchange were performed during the period of January 2020 to December 2020 in the Department of Immunohematology, BJMC Civil Hospital, Ahmedabad. During the period, total 1010 plasmapheresis procedures were performed in 247 patients. Plasma separator machine marketed by Fresenius Kabi was used for plasma exchange. There were 161.
This was prospective study you have conducted.
Yes, sir.
So you got your ethical approval?
Yes, sir.
Okay.
There were 161 male and 86 of female patients. Plasma exchange done in different diseases is shown in the table. Guillain-Barré syndrome was the most number of patients. They were like 214, and the other indication was myasthenia gravis in 13 patients. Out of 247 patients in which plasmapheresis was carried out, 30 patients were pediatric and 217 were adult patients. Out of them, 67 were ICU patients. Plasmapheresis in ICU patients was done in ICU under clinicians' observations. Number of procedures per patient, most number of procedures was 5 in 113 patients. The ideal number of cycles of plasmapheresis was 5. Out of 247 patients, 153 patients had femoral and 94 had subclavian catheters. Most common complications of plasma exchange was allergy with urticaria, and the local complication was thrombophlebitis. These were mostly seen patients with GBS, where out of 214 patients who were treated with TPA alone, 156 patients were either improved or cured and didn't require any IVIG. In patients of myasthenia, 4 patients out of 13 patients were treated and showed improvement. In 214 patients of GBS, 156 patients showed an improvement, and in myasthenia and other disorders, the improvement percentage was low as compared to GBS. The major indication for the procedure is GBS. In GBS, the recommended treatment options are plasma exchange or intravenous immunoglobulins, and both have been found to be equally effective and significantly better than the conservative treatment for recovery from the disability. In children, therapeutic plasma exchange are associated with multiple and unique challenges. The procedures are often performed using evidence or experience extrapolated from adult clinical practice, which may not be evidence-based. Allergic reactions, nausea, vomiting, paresthesias, arrhythmias are the most common complications, and these events are usually mild and resolves without treatment. The results of this study states that plasma exchange is a safe and effective treatment in neurological and autoimmune disorders like GBS, myasthenia gravis, which can be used either as a definitive or adjunctive treatment option. Compared to IVIG as the only definitive treatment, plasma exchange is a cost-effective alternative to IVIG for various autoimmune and neurological disorders. Several prospective studies are needed to clarify whether the cost-benefit ratio favors the routine use of TPE treatment approach. However, in GBS patients, other studies also claim the potential benefit of plasma exchange over immunoglobulins. Thank you, sir.
Okay, thank you. I think Hitesh bhai?
Yes, we'll go to the next case.
Yeah.
Thank you, sir.
Thank you.
Apurva, you are the next participant.
Dr. Andharia and Ashit Bhai, we included this presentation only because he has not finished.
I understand. Don't worry. I understand.
This was Ishan, right? This was Ishan, right?
Yes, sir.
Yeah, Ishan.
Okay.
Apurva?
Yes, good morning, everyone. Am I audible?
Yes, clear.
Can I start, sir?
Please.
Good morning, all the respected faculty members. I am Dr. Apurva Chugh, a third-year surgery resident in BJ Medical College, Ahmedabad. I'm here to present my paper on a case series on idiopathic pneumoperitoneum. This has been prepared by me under the guidance of my PG teacher, Dr. Vikram Mehta, and my head of unit, Dr. Prashant Mehta. Pneumoperitoneum is the result of a gastrointestinal tract perforation in more than 90% of the cases. Perforation of the stomach.
Can you make it a full screen, please?
Yeah, sure, sir.
Go for slideshow. Okay.
No, not at all.
Okay, carry on with this. No problem if it is not feasible.
Just.
But I think if someone is on mobile, it might be very small, right?
Yes, for me it
I'll
is
just
very
try.
small.
I understand. Make.
Customer,
Is it okay?
don't waste your time.
Is it
Yeah,
okay?
yes,
Fine.
perfect.
Okay. Sure. So pneumoperitoneum is the result of a gastrointestinal tract perforation in more than 90% of the cases. Perforation of the stomach or the duodenum caused by peptic ulcer is considered to be the most common cause of pneumoperitoneum. It can be a result of a diverticular rupture or an abdominal trauma. It commonly presents with signs and symptoms of peritonitis, and subdiaphragmatic free gas in an upright chest radiograph is the most common radiological finding. In most cases, pneumoperitoneum requires urgent surgical exploration and intervention. However, sometimes pneumoperitoneum not associated with a perforated viscus can occur, which is then called the spontaneous pneumoperitoneum or the non-surgical pneumoperitoneum. Spontaneous pneumoperitoneum is associated with intrathoracic, intra-abdominal, gynecological, iatrogenic, or other miscellaneous causes, which I will be discussing in the latter part. Although it is not usually complicated with peritonitis, spontaneous pneumoperitoneum is characterized by a benign course and can be managed conservatively. Idiopathic spontaneous pneumoperitoneum is an even more rare condition for which no clear etiology has been established because both perforation of an intra-abdominal viscus and other known causes of free intraperitoneal gas have been excluded. Idiopathic pneumoperitoneum is usually diagnosed after negative laparotomy results. It poses significant management dilemmas for surgeons, especially when signs of peritonitis are absent or when the cause is unknown before laparotomy. And now I will be discussing my case scenarios. Case scenario 1, a 70-year-old gentleman presented to us in the surgical OPD with complaints of upper abdominal pain for past 2 months with no other associated complaints of fever, vomiting, melena, constipation, loose stools. There were no other comorbidities and no past surgical history. Patient was vitally stable and abdominal examination was unremarkable.
Madam, speak precisely. Just don't read. We can read. You just make your own statements. So that we can finish it on time.
So all the routine blood investigations were within normal limits, and the chest X-ray revealed a subdiaphragmatic free gas and the both domes of the diaphragm. We investigated further, and ultrasonography abdomen revealed an ill-defined collection with echoes and debris along the anterior-superior surface of the right lobe of the liver, pushing the liver inferiorly. We further investigated with a CECT abdomen pelvis, which suggested possibility of a gallbladder rupture with infected loculated perihepatic collection. Initially, we did a ultrasound-guided Malicot catheter drainage, which was inserted under local anesthesia, and around 200 cc of pus was drained with an output of around 50 cc per day for the next 6 days. We discharged the patient with the Malicot in C2 after 7 days and followed him up with a follow-up USG after 15 days. And again, after the next 15 days, when he visited us, the collection size increased and there was no output in the drain. The patient, when the blood investigation was repeated, the patient developed leukocytosis. The WBC count had increased, and the patient was again readmitted and was posted for a diagnostic laparoscopy, which was later converted to an exploratory laparotomy. We had drained around 300 cc of pus from the anterolateral aspect of the liver, but there was no perforation found in the GB, in the stomach, duodenum, or in the bowel. Appendix was also normal. There was no site of perforation that we could localize. The patient was exploratory laparoscopy was done, and drain was kept in the pelvis and in the right iliac and the Morrison's, and then abdomen was closed. Post-operative period was uneventful, and the patient was discharged on post-operative day 8, and patient was asymptomatic when he came for follow-up after 15 days. In the second case scenario, a 28-year-old gentleman presented to us in the surgical OPD with complaints of bleeding per rectum for past 6 months and no other associated complaints. There were no comorbidities and no past surgical histories. Patient was vitally stable and the abdominal examination was unremarkable. All routine blood investigations were within normal limits. Per rectal examination showed anal skin tags with no other fissure or sinus, and a proctoscopy revealed a grade 2 hemorrhoid at 3 and 7 o'clock position. Patient was investigated further and chest X-ray showed free gas and the both domes of the diaphragm. Ultrasonography abdomen was unremarkable, but CECT showed intraperitoneal free air. Exploratory laparotomy was done, but no hollow viscous perforation could be found. There was no free fluid in the peritoneal cavity, and all the abdominal viscera was found to be normal. Post-operative period was uneventful, and patient was discharged on post-operative day 8. When the patient visited us for follow-up after 15 days, after a month, there were no symptoms. Patient hemorrhoidectomy was done. And again, when the patient came for follow-up after 15 days, the patient was completely asymptomatic. In the third case scenario, a 50-year-old gentleman presented to the surgical emergency with diffuse abdominal pain and multiple episodes of non-bilious, non-projectile vomiting and complained of not passing stool and flatus for past 1 day. On examination, patient was vitally stable, and on abdominal examination, there was diffuse tenderness but no guarding or rigidity. On per rectal examination, there was soft stool and no other findings of melena or any other features. On blood investigations, the complete blood count revealed leukocytosis, and rest of the routine investigations were within normal limits. Patient was RT-PCR COVID-19 positive. A chest X-ray revealed free gas and the both domes of the diaphragm. Ultrasonography abdomen showed mild to moderate fluid in the peritoneal cavity with possibility of air foci. Patient was
So how many case scenario you have?
So I have 5 case scenarios.
It's
That's
not
why, madam, I
possible.
asked you to sum up. Okay, go to your discussion and conclusion.
Sir, spontaneous pneumoperitoneum is associated with intrathoracic, intra-abdominal, gynecological, iatrogenic, and other miscellaneous causes. It has been attributed to several thoracic causes like barotrauma, pneumothorax, bronchopleural fistulas. In extremely rare cases, scuba diving and pulmonary sepsis can also cause spontaneous pneumoperitoneum. Pneumatosis cytoides intestinalis is the most common abdominal cause of non-surgical pneumoperitoneum. In women, pneumoperitoneum after rough sexual intercourse or after jacuzzi usage has also been reported rarely, because the air can be transmitted to the peritoneal cavity through the vagina. Post-laparoscopy and post-endoscopic procedures like colonoscopy also may lead to iatrogenic spontaneous pneumoperitoneum. By exclusion of perforation of the hollow vista and other known causes of intraperitoneal free air, such as rupture of the diverticulum or traumatic causes, a diagnosis of idiopathic spontaneous pneumoperitoneum is well established by exploratory laparotomy. This is consistent with the previous reports of spontaneous pneumoperitoneum. In our case series of 5 patients, we found no definite cause in spite of a thorough examination. So the etiology remained idiopathic.
Okay.
A thorough history and physical examination combined with the appropriate laboratory tests and radiological techniques are useful tools in identifying patients with non-surgical pneumoperitoneum and avoiding unnecessary operations.
Okay.
How do you judge to keep the patient conservative or to go for surgery?
So initially, when we based on the vital status of the patient, if the patient is hemodynamically stable, we can consider for a conservative management initially.
Only hemodynamic status is considered?
So hemodynamic status, blood investigations if reveal a leukocytosis.
No, I am not interested in blood investigation. What else do you consider for keeping the patient of pneumoperitoneum conservative?
If the patient is not presenting in shock, we can keep the patient.
You would wait for the patient to develop shock?
After initial resuscitation, we
the fact that you need resuscitation means patient requires surgery. Right? So in which patient did you consider conservative approach?
Conservative means not invasive. Not invasive.
Not invasive.
Is it same?
You are
Dr. Apurva?
You are telling only hemodynamical status, shock, and leukocytosis and all. What I am interested is a single statement.
Okay, what is the problem with the free gas? It is a gas is killing or something else? Peritonitis, no?
If the abdominal examination shows guarding rigidity, if there is diffuse tenderness, means patient is developing signs of peritonitis.
Suppose the patient has no generalized guarding tenderness or diffuse tenderness. Patient has only right hypochondriac tenderness and free gas. Will you operate or not?
So we can investigate the patient with.
No. Just yes or no.
Free gas under diaphragm and tenderness, and as per your statement,
no,
you needed resuscitation. Will you operate or keep conservative?
No, sir. We can keep conservative.
Really?
Conservative means no drainage also.
So we only not laparotomy, but we can consider for a percutaneous drainage.
For a free gas. Why not laparoscopy?
So in our scenario, in our system, in the emergency setting,
You may not have
We may
scopy
not have
available.
endoscopy available in the emergency setting.
Laparoscopy, not endoscopy.
Endoscopy, yes.
Yes, ma'am. We can consider for a diagnostic laparoscopy.
Okay.
Okay. I think next candidate, should we go?
Yes, yes.
Thank you, sir. Thank you.
Thank you.
Thank you, ma'am.
The next two candidates for this session.
Sir, Vimal and Devang, yes, Vimal and Devang are pending. Both of them are from BKS Medical Institute, Vadodara. They are having network issues there.
Okay.
Is Vimal with us?
I am not
Vimal,
able to see him in the list of participants.
yeah, he was just on station 2 a while back. He was asked to join station 1, but he has not joined yet. Sir, Asit sir, Andhare sir, can we wait for 5 minutes?
No problem.
The second candidate who is still remaining?
Both of them, sir. Devang and Vimal, both of them are from BKS
Baroda.
Medical Institute, Baroda.
Okay, okay, fine.
We can wait because BKS is Vagoria, no?
And
yes, sir, Vagoria.
Our session timing are not over. No, not
Yes,
yet.
Yes, sir.
We can wait.
We can wait.
Yes, sir. I'll try to contact them again.
We
Sir.
have
I'll just
kept
give.
some space for adding 2 residents if
Yes,
more
yes.
residents are present.
No problem, no problem.
So
Because this
there
is the last
time
chance.
for that.
After that, they have to appear for the exam.
After that, they have to appear for exam. See, initially, we were thinking in BJMC we were having only 5 residents. We had not presented because they sent in the ASICON a paper, but it was converted into the poster.
Okay.
So we planned that we should allow them to present, but at the end, you can see 46 participants. It's a great thing.
Yes.
Vimal has joined. Vimal?
Unmute yourself.
Yes, yes, sir.
Okay. Vimal, can you start screen sharing?
Yes, yes, ma'am.
We insisted them to send their presentation so that in case they are not able to share, we can start it.
I am sharing.
Vimal is here. Great. Vimal has joined. Great.
ટોટલ કેટલા પેપર છે
Total.
બધા સેશનમાં થઈને
સર ટોટલ 29 છે 28 સર સોરી 28 પેપર્સ
તું ઇન્ડિયામાં જ છે કે હજી ત્યાં છે
ના સર આવી ગયો અહીંયા અમદાવાદ જ છું સર
વચ્ચે મેં એને અડધી રાત્રે હેરાન કર્યો હતો
અરે સર એવું
કેમ શોધાયો
મેં એક કામ હતું તો મેસેજ કર્યો હતો બીજે નું
અચ્છા ઓકે
વિમલ if you are ready carry on
Vimal,
Yes, sir. I'm ready for.
Vimal, I can share your paper. You can stop the screen share from your side.
Okay, ma'am. Okay.
They should learn. They should have one separate pen drive on which only one paper should be there. So this problem do not occur. To search for the presentation.
અમે એવું છે મેડમ છોકરાઓને આવું થાય ને ત્યારે આપણને બહુ આનંદ આવે કે આપણને આવડે છે
ના આપણે પણ થાય પણ એટલે આપણે કેમ શીખવાડીએ કે તમારે આવું કરવાનું એમ
ના ના યાર એક્સપર્ટ જ હોય
આપણે જોઈએ પછી આપણે એમને શીખવાડીએ કે આવું કરવાનું
કોમ્પ્યુટર હેંગ થઈ જાય આ તે બહુ બધા ઇશ્યુ થાય છે
Okay, we are ready. Vimal?
Yes, ma'am. Okay.
Okay, start speaking. Yeah.
Okay. My paper, sir. One second. I can't. Look.
Julie, you go back and this enlarge the font size.
Okay, I'll try.
Okay.
Okay.
Good morning, sir. My name is Vimal Vora.
Yeah.
I'm first year residency. My
Are you
topic
able
is
to
liver abscess and
make it as a full page?
Okay.
Ma'am, this is the highest. This would be the highest.
Hello.
This is the presentation that he has sent, so I won't be able to make change.
So Vimal, what you can do is you have your presentation. Is it there? Can you open it in your
Yes,
laptop?
yes. My presentation is ready. My first page. Please share my slides. Yes.
Ma'am, he is not
Okay.
able to share, so I am sharing his slides.
Okay.
Okay.
My
Now you read from your slide
okay.
without sharing. Okay.
Okay. My topic is clinical profile management of liver abscess and percutaneous pictal catheter. My guide is Dr. Haripal Maharal sir and Dr. Ketul Shah, associate professor and assistant professor. Okay. I am from Sumandit Vidyapit, SPKS. My topic is management of liver abscess has advanced in this era, which many patients wanting its non-surgical treatment. Percutaneous drainage with ultrasound guide is one such minimal invasive procedure for management of abscess, with its own uh, limitation and advantage. We have undertaken this study at our institute to study clinical profile and management of liver abscess. Two type of liver abscess, pyogenic and amoebic liver abscess. So we in methodology, all patients enrolled after taking detailed history and ultrasound was done. After going consent and ultrasound guided pictal catheterization was inserted, incision was done under local anesthesia. Post procedure, all the parameters were observed and antibiotics was given, and depending upon drainage of pus, patient were followed. We took swab for pus and sent for culture and sensitivity. According to the we give treatment. Mostly we prefer injectable metronidazole and enteroquinolone.
Vimal, hello.
Sir.
Have you included, or means you have done pictal catheter drainage of all size of liver abscesses?
No. Enlarge above the 50 cc, 30 to 50 to 100 cc, more than 50 to 100 cc, we go for pictal catheterization.
50 and 100 is a, it's
50
a very,
cc. No, more
either
than 50
100
cc.
50.
No, more than
Or
50
you mean to say
cc.
that above 100 you do something else? There can be two conclusion.
First, no, above pictal catheterization is on superficial. If it is superficially in the liver of outer side of cordon, then we go for pictal catheterization.
Right. That we understand, because if it is near to the some major vessel, you won't have put this thing.
We can't go for pictal catheterization.
But there is some demarcation, size regarding up to which you can, after which you may for smaller size, I think pictal is not recommended. I mean, it is not required.
You just do aspiration and it should be okay. And drug therapy.
So is there any inclusion criteria you have kept?
Yes.
No, that you must be knowing. There is no need to read. You must be knowing.
Yeah. Inclusion criteria, above 100 cc, we go for pictal catheterization. Below 100 cc, we go for pus drainage.
Okay.
Yeah. And we go for antibiotics, and if it is not liquefied component, we wait for liquefied component.
What antibiotics?
For
what antibiotics you give?
Injectable metronidazole.
What is the dose recommended? What is the dose recommended for liver abscess? Metronidazole dose for an adult?
Metronidazole metronidazole dose in a double strength 100 cc 8 hourly. If high liquefied, and antiretroviral 250 milligram tablet.
How
Two
much?
tablet
How much
TDS.
dose of tablet?
250 milligram.
250
2 to 2
milligram.
morning, afternoon, and evening.
Is this a pyogenic
400
abscess or
milligram.
amoebic abscess you are dealing with?
If it is amoebic abscess, we go for enteroquinol, and it's pyogenic, then we go for metronidazole until pus culture report is come.
250 milligram of metrogyl tablet is available.
400 milligrams, sir. 400 milligrams. No, metronidazole injectable form. 400 milligram metronidazole and 250 milligram enteroquinol.
Okay. No problem. How you selected your, I mean, straightways you have placed the pigtail catheter above 100 cc in all the patients?
No.
So?
Pigtail catheter.
All the patients who present with the more than 100 cc of liquefied pus approachable, you straightway put the pigtail catheter in your all the patients?
No,
Is it a
all
standard
patient,
technique at your institute?
No. If it is right lobe of liver in upper outer quadrant, then we.
That is okay. You already said it is, if it is not near to major vessels, you will put, otherwise it will be excluded. But straightway you put the pigtail in all the patients, or you give them, or rather you give them this aspiration trial and you wait for the recurrence.
Yes, sir. Yes, patient. Yes.
Means I'm not clear. I mean, Hitesh, તમને કઈ ખ્યાલ આવ્યો એ સેમાં કયા
You
પેશન્ટ
say yes. You answer what sir gave you the.
Yes, sir. We go for first aspiration. If we know, if it's not.
So you have selected, I mean, you have put the pigtail in the recurrent pyogenic abscess. Am I right?
Yes. Pyogenic abscess. Yes.
પાયોજેનિક તો ખરું, પણ રિકરન્સમાં મૂકતા હતા કે સ્ટ્રેટવે પહેલામાં જ પિક્ટેલ મૂકી દેતા હતા? ઓકે, ચાલો જવા દે, આગળ વધશો. કન્ક્લુઝન બોલો. થીસિસ છે ભાઈ તારી?
ના, પેપર છે સર.
ઓકે.
અલ્ટ્રાસાઉન્ડ ગાઇડેડ peritoneal drainage catheter.
આ તારો ડેઝર્ટેશન છે એમ પૂછે છે સાહેબ.
No, sir. This is not my dissertation.
Okay. કઈ વાંધો. ચલો કન્ક્લુઝન બોલ ભાઈ.
USG guided pigtail catheter drainage after abscess is cost effective and minimal invasive procedure for liquefied and partially liquefied abscess.
જો અમે નથી વાંચી શકતા, તું કદાચ પહેલી વાર વાંચી રહ્યો લાગે. એવું છે?
ના સર.
તું સરખું બોલ ને ભાઈ, કારણ કે અમને કૌસ્તાને કોઈ વંચાતું નથી એટલા માટે તને કહીએ છીએ. ડિસ્કશનમાં શું હતું?
Read your conclusion properly.
હા, કન્ક્લુઝન પ્રોપરલી બોલ ને. તને ખબર તો હશે ને કેટલા પેશન્ટમાં રિકવરી થઈ, કેટલાના કોમ્પ્લિકેશન થાય, એટલું થોડુંક તો બોલી દે.
Almost 70 to 80% patient recover and her total count dropped after 3 to 4 days after pigtail catheterization, and her and hepatic liver function is normalized after pigtail catheterization within 2 to 3 days.
The time is
okay. Chalo.
Where is the amoebic liver abscess common in liver?
maybe clear abscess
in which part of which lobe or which segment of the liver it is common?
6, 7 segment.
No, lobe, right, left.
8. Right lobe.
Why? Why? From where does liver get infected? The organisms enter through what route?
Portal of entry.
Enter from yes, cecum and ascending column.
અરે એમની portal of entry હું કહું તો છું.
Cecum ને એમાંથી ક્યાં જાય?
Portal drain from
Yes, you are right. Be confidently.
Portal vein.
Speak confidently.
Any anatomy?
Inferior mesenteric artery and then
vein.
Portal vein.
And then portal vein and enter into liver.
Sir. Any anatomical relation to consider why it is common on right lobe of liver, in right lobe of liver? Okay.
The next candidate I have applied.
Available.
Next is Devang.
Devang is just joining station 1. He is done with his station 2. He'll join in 1 minute.
Okay. Is the last candidate?
That is the last candidate of this session, sir.
Right.
ત્યાં લોકોને બધા બાકી હતા એવું હતું પ્રેઝન્ટેશન સ્ટેશન 1 ને 2 ને બધાય
તું કહો છો
એટલે
સર
બધું બાકી હોય લોકોને જેને કે
પેલામાં પોસ્ટર હશે
આ લોકોને સર નેટવર્ક ઇશ્યુ ના લીધે આ લોકો અહીંયાનું પતાઈ ના શક્યા અને એમનો પોસ્ટરમાં ટર્ન આવી ગયો એટલે મેં સેટ એવી રીતે કરેલું કે પહેલા પોસ્ટર
પેપર બધું જ બાકી
નેટવર્ક ના લીધે બંને પાછળ
નો પ્રોબ્લેમ
I think that he is ready.
Yes, he is ready.
Good morning, sir.
Please.
I think this must be last one.
Yes, sir.
Devang, you share your slide.
Yes, ma'am. Just. So actually, I am not able to find my file.
Julie, do you have the presentation?
Yes, Vijay bhai, I will share his presentation.
Yes, please share.
So Devang, now you do not share. Julie will and you will speak.
Just a second.
Yes. Good. Wow.
Okay.
Primary.
Okay. Good morning, respected faculties, clinics in infected laboratory wounds, and by reference of Dr. Vipul Gujar sir, professor and HOU of Unit 2, Sumandip Vidyapit.
Is this your thesis topic?
No, sir. Actually, my thesis flavin and glycerin and betadine
This is-
ointment.
I am not asking your thesis topic. This is not your thesis topic, right?
No,
This is
yes,
your.
sir.
हाँ, चलो आगे जाओ.
Next slide. Julie, next.
Yes.
Next slide.
Exploratory laparotomy is
introduction
one of
okay,
one of the
okay.
most.
Okay, next slide.
Next करो. Material and method. I mean, objectives, material, method, aims and objective. Yes.
The purpose of the present study was a comparison of a primary wound closure technique and delayed wound closure technique with respect to rate the wound infection and duration of hospital stay. Method. The study was a prospective or observational study on the patient admitted in a surgery emergency department, Dheeraj Hospital, with a perforation peritonitis who underwent exploratory laparotomy during.
Your audio has stopped now. Hello. I can't hear him. Anybody is hearing him?
No.
Was inserted in some case followed by screening. However, the delayed wound closure group B after
So
closure of the muscular.
how you have selected A and B patient?
Randomized.
No, randomized means you are depriving one patient from some result. In your unit, you have selected both the category A and B?
Yes, sir.
Huh?
Yes, sir. Means if there is a two patients of a perforation, one will be operate by group. One will be operated by delayed wound closure technique, or one will be operated by
Yes,
primary.
I understand how you
closure
have
technique.
selected these patients. What was your randomization method?
Randomized, divided with same
In
age.
most of the patients, we randomize it by odd and even number. All the first patient will be this.
કઈક મેથડ હોવી જોઈએ ને પહેલા કે A ને લઈશ A1 ને 3 ને ઓડ વાળાને A માં મૂકીશ even વાળાને B માં મૂકીશ એવું કંઈક તો હોય ને because you are doing in your unit, that is why.
What you have done? How you select?
Simple randomized, like
simple randomized. તે સ્વયં વાળું ભર્યું છે બાકી છે તારે?
નહીં સર બાકી.
સારું ભરી લેજે. ચાલ આગળ બંધ.
સારું નેક્સ્ટ સ્લાઇડ જવા દો.
જવા દો આગળ. રિઝલ્ટ બોલો.
The study was concluded among 54 patients. The study subjects were divided into two groups, with the primary closure being done in 27 subjects, and the delayed wound closure is in the remaining 27 subjects. Among the primary wound closure group, 11.1% had a wound infection in a post of 3 days, where among those who underwent delayed closure, only 3.7% had a wound infection on post of 3 days. Next slide, please.
How many days follow-up period you have continued for this? Post-op period?
Post-op period, sir, post-op 10. Post-op 10 days. 10 days.
After that, if infection occurs? 1 month.
No, sir.
Okay. So tell us.
10 days, 10 days, then 1 month, then after 6 months.
What was your results?
Among the primary wound closure, my result is closure have a good result among infections or post-op complications than the primary wound closure.
Which are the complications you encountered?
Suture site abscess, or suture site infections, like sometimes sinus tract formations also occur.
For that purpose only you are doing delayed secondary, delayed primary, just to prevent suture site infection and abscesses. Then
Abscess, and then sepsis can be also occur, and
you know the grading of SSI when you are talking about infection, surgical site infection?
No, sir.
Yes?
Don't know, sir.
No? અરે આખું સ્ટડી કર્યો છે ને ભાઈ. સારું ચાલ. બીજા કોઈ કોમ્પ્લિકેશન have you encountered like incisional hernia, burst abdomen?
Yes, sir. Three patients have post-op complications of incisional hernia after six months. When patient came to OPD, then they have complaint of three patients have incisional hernia, and one patient have burst abdomen.
In group A or B?
No, sir, group A, primary wound closure technique.
Right. Okay, chalo conclude karo.
There was significant reduction in rate of wound infection after delayed closure of contaminated wounds. Hence, the strategy of delayed wound closure seems to be better than a primary closure in decreasing the rate of SSI.
Devang, do you know what is the incubation period of organisms to get these wounds infected? Commonly, usually the wound infection or the infection does not occur in first certain hours. Do you know what is that period usually for all common organisms?
Sir, Staphylococcus aureus.
No. You have considered post-op day 3 as your day for assessing the infection. 48
Sir,
to 70 organisms incubation period. So usually patients do not show the sign symptoms of this infection. You have ended it at 3 day post-op day 3. Right. And any selection criteria for this wound closure? All were infected or randomly you have selected?
No, sir. Clean, contaminated, and contaminated.
Okay.
Time is up, sir.
Okay.
Time
is up. Thank you.
Sir,
thank you, sir.
Hello. Thank you, everybody. I think our session is done, right?
Yes, sir.
Yes, thank you.
Okay,
thank you, madam.
Hitesh bhai and Ashit bhai, thank you very
Thank
much.
you, madam. Thank you.
Thank you, Hitesh, Asit bhai. Thank you.
Thank you, Saib. Thank you.
I was in station 2. That's why there was okay.
No, but this is a good.
One more session. I
Otherwise,
think Nehal is there.
આપણે જરૂરી હતું. અધરવાઇઝ સાહેબ ને તો બધાનું રહી જાતા.
રહી જાત એટલે
Yeah, that was the main reason.
ભલે જે રીતે થયું પણ it's a very good.
સાહેબ સિટી મારી ચલો છેલ્લી ગાડી ઉપડે છે. ના સારું આટલું વિચાર્યું નહીં તો
yes, રહી જાતા.
Thank you very much.
ચાલો.
હોય મેડમ. ચાલો.
Nehal bhai, welcome.
Are you there, Mukesh?
Thank you, madam. Thank you. Good morning, madam. Nina ben.
Good morning. Good morning.
હવે તો afternoon થઈ ગઈ. Sorry.
આપણે મળીએ એટલી વાર good morning.
You can stay on.
હા બરાબર છે બરાબર છે.
Prujal, Mukesh is there?
Sir,
I'm unable to see him. Sir, નથી hai. He has not joined.
I think he was to join at 12. That's why I might now just phone him.
હા એટલે હજુ 6-7 મિનિટ બાકી.
Kavan, you can start with the screen sharing it. The first participant, that is Dr. Kavan Takwani.
Kavan Takwani left.
But
You know, connection must have been a problem.
Internet is the only issue we are facing. As soon as Julie said share your screen, he left.
Okay, so we'll go with the next participant, Dr.
No, wait, Julie, we still have 5 minutes. Wait, let Kavan rejoin. Don't worry, we still have 5 minutes, and Mukesh sir has not joined yet.
Okay.
Shall I?
I talk with him. He is joining. Mukesh is joining. I talk with him.
Yes, great.
Julie, you can call Kavan.
સોલામાં કેવું છે નિહાલ હવે?
નેહલ
શાંતિ
પેશન્ટ કોવિડ કેમનું ચાલે છે?
નહીં ઘણું ઓછું હવે તો 45 થી વધારે નથી.
ઓકે
ઓન અ ડેલી બેસિસ એમ. હા
સરસ સરસ.
ક્રિસમસમાં લોકો ભેગા ના થાય તો સારું છે, નહીં તો પાછું હતું એ થાય.
પણ હવે તો ક્રિસમસ જો કે લોકો થોડુંક તો ડર્યા તો છે આ દિવાળીના એક્સપોઝર થી. પછી તો ખબર
Hello.
નહીં. યસ.
Good afternoon, sir. I am Kavan Takwani. I have just joined from my colleague's account as I was having net connection issues.
Next connection issue is there. Just a minute, we'll wait for a 1 or 2 minute.
Yes, sir.
I think you're joined by Dr. Jay Chotalias.
Yes, sir.
Okay, fine, great, no issue. Just a minute, you still have a time, don't worry. At least you can start sharing your screen, so that will be saving the time.
Okay, sir.
I think Mukesh has joined.
Yes, I can see his name.
I also seeing his name.
He's still in the process. His audio has not joined. He's in the process. Yes, he has joined. Yes.
Mukesh, unmute.
Hello.
Welcome, Mukesh.
I think unmute and unmute. He has unmuted, but video is not seen. Mukesh.
Mukesh, your video is not seen. Yes, now you are seen. Okay.
Yes, welcome. So now you can start.
Good morning, sir. Good morning.
Good morning. Nehal is there with you, right?
Good morning, Mukesh bhai. I am Dr. Nehal at the other end.
Good morning, sir. Good morning. Kem છો?
Okay. Yes. Continue. I'll be leaving. Okay.
Okay, sir. Thank you, sir.
Okay.
Kavan, you start.
Yeah. Can you just share my presentation, please?
Okay, Kavan, I'll try. You can start.
Hello.
It's not seen.
Yeah, the PPT is not visible.
Julie, PPT is not visible.
It is seen from my side. I'll try to share again.
Yeah, because your laptop is seen.
Is it seen?
Yes, now it is seen.
Am I audible?
Yes, start.
Yeah. Yes. Okay. Good afternoon, everyone. I am Dr. Kavan Takwani, second year resident at Karamsad Medical College. Today I'll be presenting a comparative study on wet collagen tracing versus conventional silver sulfur diazine tracing in partial thickness burns. Next. Burns injuries are extremely complex in their occurrence and pathophysiology. WHO defines burns as destruction of some or all layers of the skin when they come in contact with hot liquids, solids, flame, lightning, or radiation injury. Its optimal treatment requires holistic approach, but mainly it concerns about the tracing. Ideal management of burns is an economical, easy to apply, readily available dressing that will provide good pain relief, protect the wound from infection, promote healing, prevent heat and fluid loss, be elastic, non-antigenic, and adhere well to the wound and waiting for spontaneous epithelialization of the partial thickness burns. Next. The SSD dressing has become a drug of choice in burns dressing due to its broad spectrum action against gram-positive and gram-negative bacteria as well as against fungi. But the main concerns are the systemic absorption of silver, and also it has to be repeated daily or at least alternate day, and they are painful dressings. Whereas collagen is an endogenous substance which forms an important structural component in connective tissue and is of special importance in the skin. Collagen creates the most physiological interface between wound surface and environment, which are impermeable to bacteria. And its advantages are easy application and also being natural, non-immunogenic, non-pyrogenic, hypoallergic, and pain-free. Next. The aims of my study are to compare effectiveness of collagen dressing in partial thickness burns over SSD, and also to compare the outcome of collagen dressing in terms of infection, healing, pain score, resultant scar, patient compliance, and cost effectiveness. We have studied 60 patients over 6 months of period, in which 30 patients were applied collagen dressing and 30 patients were treated with sulfur sulfadiazine dressing. Next. We have included all the patients with partial thickness burns, including any surface of the body area, and also on presenting on any post-burns day in which burns wound is not infected. We have excluded the patient having full thickness burns who are vitally unstable, patient who has infected burns wound on presentation, patient who have electric or radiational burns, and burns over face and perineum. Next. The material used were reconstituted type 1 collagen sheets, 1% sulfur sulfadiazine, and dressing with cotton pads and roller gauze. For application of collagen, first the burns wound was soaked with normal saline and cleaned. After that, wet collagen sheets were dried with normal saline and applied over the surface area. Then it was allowed to dry on its own. And after it was adherent to the skin in few hours. Till then, patient was told to remain immobilized. And after that, it was allowed to fully epithelize and healed on its own. Next. So, comparing the results, infection rate was seen in 23 out of 30 patients in the sulfur sulfadiazine dressing, whereas in only 2 patients out of 30 in collagen dressings, which shows a 77% infection rate in SSD, whereas only 7% in collagen dressings, which is quite beneficiary for the patients. Also, comparing the VAS score out of 10, the silver sulfadiazine dressing had 5.5, whereas collagen dressing had a less pain score of 2.85. The days to the healing were 25.7 days in silver sulfadiazine dressing, whereas 13.5 in collagen dressings. Resultant scar were considered good when less than 50% of the body surface area had contracture. In silver dressings, 21 out of the 30 patients had a good resultant scar, whereas all the patients of collagen dressing had good resultant scar, giving 100% good resultant scar rate in collagen dressings. Patient compliance was 18 out of 30 in SSD dressings, where 28 out of 30 in collagen dressings. Next. So here is a 70-year-old male with superficial skull burns over the lower limb. We can see that the burnt area is nicely covered by the collagen sheet, and it is allowed to dry on its own. Another one is a 2-year-old female child coming to trauma with superficial skull burns involving 35 to 40% body area. Can you please play the video? The video of the baby, just below the 2-year-old. Just click on the video, please. Yeah. So we have applied collagen primarily in the trauma. After giving analgesics, sedatives were not required, but in pediatric age group, it may be required. We can see the image of the post-burns day 180, on which it is a completely healed wound with a formation of a small keloid over the back, which was dealt with accordingly. Another one is an 18-year-old male child with superficial skull burns involving 45 to 50% body surface area. We can see on post-burns day 1, it is a hyperemic wound. And on post-burns day 90, it is completely healed with a very good resultant scar and no contractures. Another reason is a 19-year-old male with grade 2 flame burns involving 75 to 80% body surface area. On post-burns day 180, patient is completely mobilizing without any contracture, no hypertrophic scars or keloid will seen on the wound, and it was cosmetically very good. Next. So hereby we can conclude that collagen dressing is an ideal dressing for partial thickness burns, as pain was significantly reduced in patient dressed with collagen, as it forms a temporary barrier which prevents any external source of stimulation of the nerve endings to cause pain. Also, it helps to form a mechanical barrier between wound and environment, which prevents the infections. It also gives the faster rate of healing which is due to the property of optimum environment for early wound healing. Also, it is granulation forming and epithelialization forming. So the scar tissues are good, and it is also more cost effective. Also, it is not statistically significant as of now. Whereas SSD has disadvantage of large number of dressings, prolonged hospital stay, amount of pain, loss of time and labor to the patient and the accompanying person, which makes collagen dressing more effective. Also, we can see that in comparison to other such studies, we have also included pediatric age group and partial thickness burns involving any % of the body surface area. So we can say that this is a revolutionary finding in our paper. Thank you.
Okay, doctor. What is your name, doctor? I guess it is not Jay.
Dr. Kavan, sir.
Kavan, acha, ha. Yeah. So what is your conclusion?
Sir, we can conclude that collagen dressing is has many significant values than silver sulfur dressing in partial thickness burns, as it is giving less pain to the patient. Also, it is a single time dressing, so patient compliance is more. The resultant scars that we have endured are very good in comparison to the silver sulfur dressing. Also, the rates of secondary infection were very less with collagen dressing.
And so how do you rate the cost factor on collagen vis-a-vis
in patient having larger burn surface area, the repeated use of silver sulfur dressing and the material used are significantly for longer period of time. So eventually the cost were around equalish in collagen dressing and silver sulfur dressing. So that was not a big factor for the patients.
Okay. Mukesh bhai, tamare koi question?
No question.
Okay. And
so you didn't do any dressing at all, as you said just before 1 minute.
Sorry, ma'am?
You didn't do any dressing of these patients, only one dressing.
Ma'am, in the patient in whom we have applied collagen on the post-burns day 0, it was only the first time dressing, which was done after cleaning with the normal saline when the burns wound was not infected. It is a single time dressing. After application, we do not remove the dressing. It comes off it on its own after the tissue beneath it is epithelialized.
How many days required for dressing?
Ma'am, the normal time of healing in our study is 13.5 days, but it is approximately around after 15 days, the dressing comes out on itself. It peels off and the underlying skin is epithelialized.
Okay.
So it is a single time dressing.
There is no discharge beneath the collagen.
Sir, in out of the 30, in only one patient, we acknowledged that problem of patient having a slight pus formation, which was accumulated beneath the collagen sheet. We just put a nick over the sheet and the pus was drained, after which patients that wound healed completely. So we have not acknowledged that problem in any other cases, sir.
So you have not removed the sheet.
No, ma'am, we have not removed the sheet. Only a nick was kept.
Required changing. Rest of the dressing
no, ma'am,
requires
the sheets were not changed. Only one
but
nick was kept
overland
over
dressing
the sheet
requires
first
change. Okay.
Yes.
Okay. Time is up.
Thank you, ma'am.
Okay, next participant is Dr. Kapil. Kapil?
I am sharing my document.
Can you share your screen?
Yeah. Is everybody able to see?
Yes.
No, we cannot see you.
Kapil, keep your video on.
Okay. Is it okay? Hello.
Yes.
Speak loudly.
Good afternoon, everyone. This is Dr. Kapil Kacharia, third year resident from PDUMC Rajkot. My topic is a comparative study of the open versus closed method of creating pneumoperitoneum in laparoscopic surgery. The main challenge facing the laparoscopic surgery is the primary abdominal access, as it is usually blind procedure and associated with many complications. Technique for creating pneumoperitoneum is either closed technique or open technique, and many other techniques like optical trocar incision or direct trocar incision or variation of this technique. And the life-threatening complication include the injury to the bowel, bladder, or major abdominal vessel or anterior abdominal vessel. The less serious complication that can occur is post-operative infection, subcutaneous emphysema, or extraperitoneal inflammation. The purpose of the study is to describe the safety between these two techniques for accessing the abdominal cavity and creation of a pneumoperitoneum in laparoscopy. The aim of the study is to assess the practicality of both methods in creating pneumoperitoneum and with regards to hazard performance and incidence of complications. Study methodology. The observation study was conducted over a period of 2 years and 100 patients were included at PDMC Rajkot. After taking institutional ethical committee approval and written informed consent, appropriate workup is done. The patient was diagnosed on the basis of clinical symptoms, physical examination, hematological investigation, as a radiological investigation. For operative findings like method of pneumoperitoneum creation, its duration, multiple attempts, size of incision, extraperitoneal insufflation. Hello. Hello. Am I audible to all?
Yes, yes.
For operative findings like method of pneumoperitoneum creation, its duration, multiple attempts, incision size, extraperitoneal insufflation, port side bleeding, and gas leak, and total gas use were recorded. For operative complications like visceral or vascular injury, port side hematoma, or conversion to open surgery was noted. And patient was assessed in postoperative period for hematoma, wound infection, gas embolism, and port side incision hernia up to 3 months. Criteria for selection: all patients undergoing elective laparoscopic surgery and hemodynamically stable patient was included, and the patient having undergoing emergency laparoscopy, history of abdominal tuberculosis or puerperal sepsis, machinery failure for establishment of pneumoperitoneum creation, and patient having intestinal obstruction are excluded. As we can see from the graph on the right side, size of incision was more in open method is compared to closed method. I have used unpaid t-test to find the statistical significance. P value is -5.4, which is statistically highly significant, and as a result, minor complication like multiple attempts, gas leak at port side and port side bleeding are more with open method. And this same problem are in patients those having BMI greater than 25. And duration of pneumoperitoneum creation is shorter as compared to closed technique. And P value is 0. This is also statistically significant. Minor complication like multiple attempts, gas leak at port side bleeding are more with open method, while one case of preperitoneal insufflation is noted in closed method. Here, most of the cases P value less than 0.05, and all these findings are statistically significant. And wound infection occur in 3 cases: 1 in open method and 2 in closed method, which are treated successfully by antibiotic and dressing. Port side hernia does not reported in any case, but due to shorter period of follow-up, we cannot finally comment on this. Type of laparoscopic procedure has no impact in our study, as there was no specific selection criteria for the type of laparoscopic surgery. Discussion. Scheffer et al. While comparing the complication of both technique, concluded that the open access method failed to show any superiority over the closed technique. However, Bonzer et al. Found that comparison between open and closed technique found that the rates of visceral and vascular injury were more in closed method. There was no significant difference in mortality rates in our study. There was no mortality and major complication occur. In this study, we found that the open technique is faster than the closed technique. This is also similar to previous studies like Petigan et al. Is being more cost effective. Sigmund et al. Also found that the less time was required for the open method as compared to the closed technique. Zakera et al. In his study concluded that the open technique is safe alternative to closed technique for the creation of pneumoperitoneum. Such a approach has further advantage such that less cost and instrumentation and rapid creation of pneumoperitoneum. In this study, we also concluded the same. The main limitation of the study was that the number of patients, and another limitation is the incidence of port size incision hernia cannot be assessed accurately due to shorter period of follow. And this was a single center study, and like all single center study, the result cannot be widely generalized. For conclusion, we can conclude that the both methods are safe to perform. Open technique has slightly more incidence of minor complication due to large incision size, but advantage of less duration needed for pneumoperitoneum creation. But a major vascular or visceral injury does not occur in any of the group. Hence, open technique is good as closed technique for creation of pneumoperitoneum. Thank you.
Ruling out exclusion criteria that you have mentioned. So, what were the criteria that were included just for putting a larger incision?
For open technique, do you mean to say?
Yes, for open technique.
For open technique, if patient having any history of previous surgery over the around umbilicus or previous laparoscopic surgery, we have done the open technique. Like,
but that doesn't include in the exclusion criteria, previous surgery.
No, sir. The previous surgery, not all previous surgery was excluded. For example, if open appendectomy was done when we have used closed method for creating pneumoperitoneum.
Okay.
Only the procedure done around the umbilicus was selectively excluded for open.
But you can
for
use
closed.
some other port to enter the peritoneum.
Yes, sir.
What is Hassan's technique?
Hassan's technique, we have to open the sheath under direct vision by lifting up from both sides, and under vision we have to insert the Hassan's cannula, which is blinded, and after that we have to fix the both truss of the cannula to the sheath and remove the trocar for insertion of camera port.
What is the preferred site in such cases to perform an Hassan's?
Supraumbilical incision, vertical.
Supra, you cannot in a position to do anything on the region. That is why you go for other option.
We can enter from palmar part also, left hypochondrial region, and we can also enter from the right hypochondrium.
Okay, that
sorry,
is
right
fine.
iliac fossa.
And Mukesh bhai, tamaro koi question?
Yes. What was selection criteria for both methods? Which patients you use open method and in which patient you use this closed method?
No, sir. There was no specific selection criteria for any
because both methods are not give similar result in all patients. Both
Yes,
have other variables are also. So certain patients should be preferably be done by open method, and certain patients should be can be done by closed method. Majority of the patient. So this selection criteria should be there. For open method, which patients you will select, and for closed method, these variables are excluded. These variables are not there here. So both are not similar methods. There are patients variable also.
Yes, sir. But we have done open technique in most of the post-operative patients.
Most of post-operative.
Previous, in history of previous surgery scar.
Yes, and in which other cases you can use preferably open method. Simple thin and lean patient and first time operated patient.
Yes, yes, sir. And patient is having ventral hernia should be operated for open.
The patients, obese patient, when the fatty patients are there, it is not possible to reach peritoneum by only Veress needle.
Yes, sir. Patient having umbilical or periumbilical hernia should be operated by.
In those cases, open method becomes more easy and more feasible, and with less complications and less duration of surgery than closed method. So that these variables should be considered before conclusion.
So time is up.
Okay.
Dr. Kapil, you can stop the screen sharing. Dr. Krupal is the next participant. Dr. Krupal.
Yes. Good afternoon.
Good afternoon.
Yes.
You can start.
Yes, sir. Good afternoon to all my teachers. Sir, I am today presenting a case report about non-obstructing, non-refluxing congenital left giant megaureter with ipsilateral renal dysplasia in a 6-year-old male child. A case report and literature review. Abstract. Background. A 6-year-old male child was admitted for lower abdominal mass, USG, micturating cystourethrogram, CT, IVP, and MR urography diagnosed a left-sided non-obstructing and non-refluxing congenital giant megaureter with left renal dysplasia. DTPS scan was suggestive of no visual and quantitatively appreciable function in left kidney. At surgery, dilated tertius left megaureter and small left kidney was found, and left nephrouretrectomy was done. Conclusion is it is a rare condition. The physical examination and radio imaging are essential for the diagnosis of CGM. The appropriate treatment method should be based on patient-specific condition and investigations. Introduction and case report. Congenital giant megaureter is defined as ureteral dilatation, producing elongated and tertiary ureter. It presents as lower abdominal mass. It can be associated with other upper urinary tract anomalies also. Normal diameter of ureter in 6-year-old male child is generally 3 to 4 mm. If diameter of ureter is more than 10 times more than the normal, that is more than 4 centimeter, then it is called as giant megaureter. In our case, a 6-year-old male child having 70 kg weight was admitted for lower abdominal mass since birth. He had no history of urinary tract infection or flank pain. Approximately 15 by 10 centimeter size single cystic oval shaped mass was palpable in umbilicus, hypogastrium, and left lumbar region. It had smooth surface, regular margins, and it was cystic in consistency, non-tender, mobile in all directions, did not move with respiration. On percussion, dull note was present. Lump was not fixed to overlying skin or underlying structures. Ultrasound showed left dilated megaureter with internal echoes throughout its length and measuring up to 3 centimeters in its diameter. Picturating cystourethropy did not show any radio opacity, reflux, dilatation, or filling defects. CT IVP showed 6 by 1.9 centimeters small left kidney with grossly dilated tertius hydroureter, which measured 4.6 centimeter in maximum diameter till the level of bladder, which was displaced towards the right side due to left megaureter. MR urography showed small left kidney measuring 5.1 by 1.7 centimeter in size, marked left hydroureter with likely possibility of megaureter with associated ipsilateral renal dysplasia and normal right kidney. Sir, these are the imaging. First one is micturating cystourethropy. Sir, second one is CT IVP, in which left kidney and ureter are not seen. And third one is of MR urography, which is showing dilated megaureter and bladder. Sir, in DTPA scan, there was no visually and quantitatively appreciable function in the left kidney, and right kidney showed normal perfusion with compensatory cortical function and normal excretion. Sir, RFT and serum electrolytes values were normal. At the age of 6 years, surgery was done by left subcostal incision and small left kidney of approx 6 by 2 centimeter in size and left dilated and tertius megaureter of approx 4 centimeter of maximum diameter was found extraperitoneally. Left kidney and left megaureter were removed by left nephroureterectomy. Histopathological findings also confirmed atrophied kidney and megaureter. Sir, this is a photo of DTPA scan and postoperative image of left kidney and postoperative left megaureter, which was removed, sir. Sir, discussion and literature review. Megaureter has been classified as per following types according to its etiology. First one is reflux megaureter, second is obstructing megaureter, and third one is non-refluxing, non-obstructing megaureter, which can be further divided into primary and secondary. Secondary can be either due to polyuria or infection, or can be due to remaining wide after relief of distal obstruction also. Sir, in the literature, we can found several case reports in which only Huang in 1987 reported 21 cases. In rest all, only one case was reported and all were treated surgically, sir. In the pathogenesis of this megaureter, there are multiple factors contribute. As per Ostruck E. et al., it is considered to be related to the expression of transforming growth factor beta, which might lead to lack of postnatal muscle dysplasia. And as per Notley et al., by electron microscopy, they found that the major reason for megaureter is collagen fiber hyperplasia in muscular layer of megaureter with the normal nerves distribution. In the discussion, sir, the diagnosis of CGM is usually based on history, clinical examination, and imaging. In our case, the diagnosis of CGM with dysplastic kidney was made according to the physical examination, USG, MCUG, CTIVP, MR urography, and DTPA scan. DTPA scan is an important tool to find out renal function, which helps in decision making of nephrectomy. The primary treatment may be conservative, as suggested by Charnit et al., while according to Upadhyay et al., an early surgical therapy of the segmental dilatation is excision of the diseased segment with end-to-end ureterostomy. A better option is to anastomose the upper ureter end to side to the contralateral ureter. Nephroureterectomy may be necessary for poorly functioning or non-functioning renal unit, as in our case. The conclusion: CGM is a rare condition. Physical examination and radio imaging are essential for the diagnosis, and the appropriate treatment method should be based on patient-specific condition and investigation. Thank you, sir.
So, what did your biopsy reveal?
Sir, biopsy revealed that in the left kidney, it was dysplastic and pyelonephritis, chronic pyelonephritic findings were there, sir.
Above the ureter, the
And
ureter.
in the sir, ureter showed enlarged, inflamed and thickened muscular layer, sir. And it was filled with multiple inflammatory cells, sir. Most
I am
commonly.
asking for the histopathological.
Yes, sir.
Appearance.
Sir, any photo? Sorry, sir.
Histology, how did they describe the ureter?
Sir, in histology, stated that section of section from ureter showed dilated lumen lined by flattened
Dilated lumen is a gross
muscular layer showed
examination.
dense inflammatory infiltrate and was. Sir, on gross examination, it was dilated and
Gross,
distended,
I
sir.
am asking for the histopathological examination.
What is structural and histopathological abnormalities? As pathophysiology shows that there is a problem in collagen fibers.
Yes, sir.
So what was that? Only inflammatory infiltrates or anything else?
No, sir, inflammatory infiltrates. They have mentioned inflammatory infiltrates. No comments about collagen fibers, sir.
So there was no collagen or any other fibrous in the ureter?
Sir, no comment was made on that, sir, in the histology report, sir.
Okay, that is fine.
Yes, sir.
So why both CT urography and MRI both have been advised?
Sir, in CT IVP, we can mainly see the function of the kidney, whereas in MRI, it is more sensitive for soft tissues. So we can exactly see the structure of the dilated ureter and also bladder. So for soft tissue purposes, MRI is more sensitive. So it
So if
was
we
advised.
already decided DTPA should be done, DTPA will be done. So one of them can be used. Why both investigations?
Sir, DTPA was decided after CT IVP showed no function in the left kidney. So DTPA was just to confirm whether the left kidney is totally dysfunctional or if there is some function present or not, sir.
Ultrasonography also shows that there are mega ureter. There is mega ureter,
yes, sir. Yes,
and CT urography shows that there is non-functioning kidney. In CT urography, we can also have a image of mega ureter. If it is not filled with dye, but a soft tissue imaging will be there. So MRI adds no other value in plan of management, but
yes,
only cost.
Yes, sir.
To the patient. Yes, documentation, academic documentation is okay.
Yes, sir.
But otherwise, we prefer both investigations.
Yes, sir. I understand.
And what is the incidence of this type of anomaly in literature that you haven't mentioned in your discussion? Only studies are there, but literature में incidence कितना है?
Sir, actually, on PubMed, less than 10 such case reports have been reported, sir. So exact percentage of incidents.
Only one article is one article is suggesting 21 patients, and others are single. So it is more than 21 basically. Whatever literature you have served and you have. So usually in textbook, if anomaly is mentioned in textbook, there is usually incidents are there. This congenital anomaly, it is a congenital anomaly or acquired anomaly, or what is the incidence?
Yes, sir. Right now, sir.
Okay.
Okay. Thank you, sir.
I call the next participant. Dr. Nilesh Chaudhary.
Good afternoon, everyone.
Good afternoon.
Dr. Krupal, can you stop screen sharing?
Okay.
Dr. Krupal. Dr. Nilesh, you can start your screen sharing.
Okay. Ma'am, I'm finding difficulty in sharing a screen. Can you please show my
Yes,
slide?
I'll do it. Yes, I'll do it. You stop the screen sharing from your side first.
Okay, okay. Am I audible to everyone?
Yes, yes.
Yes, yes.
Okay. I'm going to present Mr. study of various modalities of treatment of liver abscess done in PDO Medical College and Civil Hospital, Rajkot. Next. Liver abscesses are a purulent collection in the liver parenchyma that results from bacterial, fungal, and parasitic infection. The primary mode of treatment of amoebic abscess is medical. However, many cases may be refractory to medical therapy. In such patients with a pyogenic liver abscess, aspiration has been the traditional mode of the treatment. In the present study of liver abscess, the following treatment modalities such as medical management, aspiration, and percutaneous catheter drainage have been studied. Uh, the aim of the study was to evaluate the outcome associated with the different treatment strategies of liver abscess. Uh, this study was conducted prospectively in the Department of Surgery, PDO Medical College and Hospital, Rajkot, and all patients were diagnosed with sign and symptom of liver abscess and confirmed by ultrasonography. All the 100 patients were admitted in PDU Medical Hospital, and the duration of the study was 1.5 years. After thorough examination, patients were admitted and underwent antibiotic therapy. Inclusion criteria were all cases of the liver abscess diagnosed by USG with age group of 15 to 75 years, and ruptured liver abscess cases were excluded. Next. Patient received the treatment as follows. Abscess cavity on USG less than 5 centimeter size were managed conservatively with intravenous antibiotics. And abscess cavity 5 to 10 centimeter size were subjected to percutaneous aspiration. Abscess cavity more than 10 centimeter underwent percutaneous catheter drainage. Patients were then evaluated and followed up to review post-procedural outcome clinically as well as by the USG assessment. Patient who did not show any sign and symptom of improvement with initially assigned therapy were then escalated to higher modalities of treatment to check for the subsequent improvement. We studied the laboratory and microbiological spectrum of the drain secretion in the patients with the liver abscess. We also compared the clinical outcome by evaluating the duration of hospital admission and by delineating the reduction in the abscess cavity. Amongst the three modalities of the management which we executed in our setup. Next. The most common age group affected was the 40 to 49 year of age, and liver abscess was found more common in males than females. Pain in abdomen was the most common presenting features, and most of the liver abscess were in the right lobe of liver. Next. Most out of 100 patients, we found that 76% was sterile and no organism were found, and 15% we found E. coli was the most common organism. And on the laboratory investigations, we found in 42% cases anemia and leukocytosis was in 53 cases. And the volume of the abscess we have noted, which was the maximum patients were in the 150 to 200 ml of volume. And mean hospital stays was maximum in conservative management, and in a percutaneous needle aspiration it was 4.8 days, and in pigtail catheter drainage it was 5.9 days. Next. In our study of 100 patients of liver abscess, we found that the pain in abdomen located in the right hypochondrium was the most common presenting feature and was found in 97% of the patients, followed by the fever was 83%. So in Malik et al. In 2015, also they found in their study that most common presenting feature was the abdominal pain and fever. After percutaneous aspiration drainage of the abscess cavity, pus was sent for the culture and sensitivity, and culture was found was sterile in 76% of the cases, and positive cultures reports were total 24%. Out of this, E. coli was the most common organism, and in Italia, HB et al. In
You can skip
2015.
this discussion.
Okay,
You
okay.
can go ahead. Yeah.
Okay, next. Based on the present study, we concluded that liver abscess is the most commonly found in 40 to 49 year of age group in right lobe of liver and commonly presented with abdominal pain and fever. Percutaneous catheter drainage and USG guided percutaneous needle aspiration both are the excellent, safe and reliable method with less hospital stay and early resolution of liver abscess. Next. It's done.
Okay. You said that by usually most of the abscesses were managed conservatively. If they did not respond, then you
Yes.
needed a higher scale of treatment. So what do you mean by that higher scale of treatment?
Initially, we have applied all patients were underwent with IV antibiotics, and if they
So that
didn't
is done.
responded, yeah,
That is a
then we
conservative which
yeah
did not respond, and you had to go for a higher scale of management.
yes
So what all includes in the higher scale of management?
it was a percutaneous needle aspiration and percutaneous catheter drainage.
Okay. So aspiration is a higher scale of treatment.
Yes, sir.
Okay.
You mentioned that there is a exclusion. You have done conservative management in less than 5 centimeter size liver abscess, but
Yes, sir.
ultrasonography suggests of liquefied 5 centimeter liver abscess. What will be the management? Only antibiotic, or you need to aspirate it?
We have for a needle aspiration, sir.
This must be so. This is not conservative management. These patients are also
Yes.
included in your aspiration
Yes.
group.
Yeah, but
It is
actually,
if it is liquefied liver abscess, even though less than 5 centimeter, you need to aspirate it.
yes.
So it is a comparative study between aspiration and pigtail, or it is only management of liver abscess? This
It
study.
was only observational study for all the three modalities, sir.
Okay, so you are not intended to comparing the all methods, three methods.
No, sir.
Did you need to go for a laparotomy in an admitted case of liver abscess?
No, sir. Actually, we have excluded the ruptured liver abscess, sir.
Okay.
Suppose there is a liver abscess in caudate lobe, liquefied 200 to 300 cc in caudate lobe of liver. What will be the preferable management?
Preferably was initial, sir. Conservative would be preferable.
It is liquefied 200 to 300 cc. You cannot keep it conservative. You need to aspirate. You need to remove pus. Yeah, either these cases must be excluded because these patients require exploration.
Yes, sir.
You know, yeah, either laparoscopy or open, but we have to explore.
Yes.
Okay, time is up for this.
Okay, okay, good.
Thank you.
The next is Dr. Vishal. Dr. Vishal.
Hello.
Please start your video also.
Hello.
Start screen share.
Okay.
Vishal, we can see you.
Please share your screen.
Yes, sir.
Now you have gone. Yeah, this. We can see you now.
there is an issue, I can share your slides.
Please share from here.
Okay.
Good afternoon, everyone. I'm Dr. Vishal Karamta, third year resident from general surgery. I have here presented the surgery, presented the study, comprehensive study between the laparoscopic versus open management of the perforated peptic ulcer. This is the prospective study done in the 2 year in the PDUMC Rajkot. Total study population was 25 in the laparoscopic group and 25 in the control group in the open method. In a enormously populated and densely densely populated country like the India, where is the one of the epicenter in the holistic healthcare center. Laparoscopic approach to the many general surgery condition have to become the standard on many surgery. With the ever changing the dynamic, achieving the under cosmetic emergency condition also use the minimal accessive approaches. Gastrointestinal perforation are the surgical condition which require the emergency exploration. With the rising trend of the laparoscopic approaches in diverse and resources country like the India, in our study we study the outcome of the bowel perforation surgery via the laparoscopic group in comparison with the open and conventional method. We also study the peroperative and the post-operative performance of the patient undergoing the surgery for the bowel perforation by open as well as the laparoscopic comparison group. Please next. In our study, our aims and objective are to study the severity and the duration of the post-operative pain and total number of need of the analgesic in open as well as a laparoscopy group. To study the total duration of the nasogastric tube and intravenous fluid and return of the normal bowel activity. To study the operative time and comparing the both group, and also to study the post-operative hospital stay in both group. Next. In material, during the duration of the study, patient after the diagnosis with the clinical diagnosis with the peptic perforation, systemically assigned a patient alternately goes on the open as well as the laparoscopic omental repair. In patient which no show any sign of peritonitis within the 24 hour early present also undergo the laparoscopic surgery. In the laparoscopic method, 10 mm umbilical camera port was inserted after the creating the pneumoperitoneum with various needle. Another 5 mm working port inserted in the left lumbar, right lumbar region on the left side in milky debris, also the in the LHC, and if they require another one inserted in the RHC for the liver retraction. Perforation which size was the less than 10 mm, which closer using the laparoscopic with silk number 20. Otherwise, there is an open conventional method was done. Patient in the post-operative period was assessed primary endpoint for the perioperative post-operative analgesic requirement. In our study, we used the injection tramadol 50 milligram per ml. Secondary endpoint of view of to see the post-operative any complication pain score on the day 1, day 3, and total number of the nasogastric tube requirement, total day of the intravenous analgesic, and a need of the total number of the day of the analgesic injection. Next, please. In our study inclusion criteria, we said all the patients between the age of the 80 to 65 year with a peptic perforation. On exclusion criteria, a patient which has the previous upper abdominal surgery for the peptic ulcer bleeding or gastric outlet obstruction, and which a patient come after the 24 like the late presentation which show the sign of the peritonitis or sepsis. Next, please. From our study, the following were the observation made in our study. It is the most common number of the case belong to the middle age group. In our study, the large cohort of the patient male-female ratio is the 2.5:1. Perforation most common in the male compared to the female, and the ratio is the 2.5:1. Out of 50 cases in our study, where the 36 patient or the male. Next, in this result, the laparoscopic and open group compare in the time of the operation. In a laparoscopic group in our study, the average duration of the Operating time was the 83.4 minute. In the open group are the 86. And a total day of the drain requirement in the laparoscopic is less 6 days average, while in open group there is the 7.8 days. Total day of the hospital say in the laparoscopic group so the 8 days, while in the open group which was the 9 days. Total number of the analgesic injection average 13 number of the analgesic required in the laparoscopic which was the 19 in the open group. Need of the IV fluid and total duration of the RT which average day was in laparoscopic group was the 4.3, while in the open group required the 5.3. Total output is also reduced, also less in the laparoscopic group, while in the which was the more in the open group. Total pen score on the visual analog score from the 10 centimeter, which was compared on the day 1 and day 3, which show the in laparoscopic group post-operative pain, which was the also less as compared to open group. Also, there is the p value, which was the significant, statistically significant. Next, discussion. Peptic perforation is the most common surgical emergency because of the nowadays there is the also increasing the adverse of the H. pylori and the H2 receptor antagonist, the proton pump inhibitor, the surgery, but the peptic perforation surgery was not done. We compared the two study. In the study, hello.
Sir, you can start with the questions.
Our conclusion, laparoscopic repair of the peptic perforation is the safe and reliable procedure, which is associated with the less operating time, less post-operative number of the
Okay,
analgesic
Vishal,
requirement.
you
Hello?
may please stop. Yeah. So now, how do you infer the reduced rise tube time in cases of laparoscopy vis-a-vis an open surgery?
Sir, both group in the post-operative period, this early sir start orally in the laparoscopic group, which is the reduced
So
as compared to sir
what do you
open.
think is the logic behind this reduced time?
Sir, early sir return to the normal sir day activity, sir.
Matlab you feel that the paradigilius stays for a shorter period in
In sir,
laparoscopy?
in sir, our study sir laparoscopic group patient in the only sir in the out of 25%, only 2 to 3% of the sir chances of the paralytic illness as compared to sir open. Where is the sir results show the 7 to 8% in the open group, sir.
Okay, Mukesh bhai.
Yes, you mentioned that clinical judgment of peptic perforation patients were included. So how you can clinically judge this patient has a peptic perforation?
In sir, patient who showed the sir in clinically as well as sir after the sir USG or by X-ray confirmation, which patient show the sir gas and the diaphragm.
Even in X-ray, you cannot surely say it is a peptic. In USG, you cannot surely say
no,
it is peptic.
No,
it is very difficult to judge clinically, except some history point of view, but it is not exact. So primarily, these all patients are of peritonitis, patients of peritonitis. And what patients are peptic perforation, you have to select those patients.
In sir, our study sir, with patients show the X-ray or clinically like the perforation undergo the diagnostic laparoscopy, in which study strongly suggestive like the sir history of the NSID or past history of the peptic ulcer disease, which undergo sir after confirmation.
Is there any conversion rate in your study? Conversion to open?
Sir, only 2 patients are undergoing the open exploratory laparotomy. Where the size are more than 10 mm or other sir causes like the sir gastric outlet obstruction or it is.
The time is up.
But false diagnosis was never the indication for opening the case.
Yes.
Never. So once you thought that this is peptic, it was peptic always.
Mm-hmm.
So you feel 100 out of 100 cases where you suspected peptic as a pre-operative diagnosis, were all peptic in the post-operative status. Okay.
Thank you, sir.
Go to the next participant. Next is Dr. Shubham.
Yes, ma'am. Yes, ma'am. I have.
So can you
What
share
is
it?
his name, please?
Dr. Shubham.
Yes, yes, ma'am.
Shubham,
Dr. Shubham
Shubham,
is here.
okay, okay. Share your screen, please.
Yes, ma'am. Ma'am, I actually you will have to share my screen.
Okay.
There is no option here.
We can see you now.
Yes, ma'am. Yes, sir. Good afternoon, all the consultants, organizers, and my colleagues. I'm Dr. Shubham Samdani, third year resident of PDO Medical College, Rajkot. I'm presenting a prospective comparative study of invagination of indirect inguinal hernia sac with excision of indirect inguinal hernia sac. Next. So background, it has been said that the history of groin hernia is the history of surgery itself. Hernia repair is one of the most commonly performed general surgical procedure worldwide. Eduardo Bassini in 1887 recommended excision and high ligation of indirect inguinal hernia sac. As a surgeon, we need to assess all the merits and demerits of any surgical technique so that our patient get best surgical treatment with less post-operative complication and better results. Recently, it is believed that ligation of peritoneal sac, which is richly innervated, is responsible for increased postoperative pain, and also the vascularized peritoneum produces a miniature peritonitis, which leads to postoperative pain, discomfort, and other complications. Next, please. Aims and objective. The purpose of this study is to compare effect of invagination of indirect inguinal hernia sac with ligation and excision of the sac on postoperative pain, early and late postoperative complications, chronic groin pain, and recurrence rate in both groups of patients. Next. So methods. This study is a single-centered, prospective, comparative, randomized study carried out in PDO Medical College, Rajkot, between June 2018 to June 2020, a total 50 patients were enrolled after proper consent, which were randomized into two groups. Group A, excision of sac. Group B, invagination of sac. Inclusion criteria: all patients with indirect inguinal hernia planned for open licensed tension-free inguinal mesh plasty. Exclusion criteria: congenital inguinal hernia, complicated inguinal hernia like obstructed, strangulated, and irreducible, complete indirect inguinal hernia, and patient with local skin infection. All the cases were followed up after surgery for 6 months on OPD basis, and visual analog scale was used to assess post-operative pain. Next. Result and analysis. This study revealed that most common age group with indirect inguinal hernia is between 21 to 30 years. The post-operative complication like seroma, scrotal edema, wound infection, hematoma, urinary retention are comparable in both groups, though the difference is not statistically significant. There is no recurrence occurred in both the groups during 6-month follow-up period. However, long-term follow-up is required for the same. Next. This is the table. This table shows comparison of pain in two groups by visual analog score at different point of time. I have recorded the pain post-operatively on 6th hour, 24-hour, post-op day 1, 3, 7, and post-op day 15, and on OPD basis follow-up on 1 month, 3 month, and 6 month. So the post-operative pain was felt less by group B, that is invagination of sac, and which was statistically significant till post-op day 15. And the chronic groin pain was found in 3 patients in group A and 1 patient in group B, which was comparable though statistically not significant. Next. Discussion. So the post-operative pain, comparing to all the study by Ottman et al., PJ Vincent et al., Hansraj Ranga et al., and S. Delcucas, all above mentioned study have mean post-operative pain less in group B, that is invagination of sac, and difference is statistically significant in all the study except Hansraj Ranga et al. Next. This is the table showing comparison between early complications like seroma, scrotal edema, wound infection, urinary retention. Early complications are comparable in all the studies, but the difference is not statistically significant in both the surgical technique in any of the study. Next. This is the table showing comparison between chronic pain and recurrence. So there was no recurrence in our study as longer follow-up is required to judge about a recurrence, and a chronic groin pain is more in group A, that is excision of sac in our study, than the ligation than the invagination of sac, but same in both groups in study by Ottman et al. Next. So conclusion.
So the post-operative pain was significantly less in case of invagination of indirect inguinal hernia sac as compared to the excision and ligation of sac. Incidence of chronic groin pain was found to be less in invagination of sac compared with the excision of sac, though it was not statistically significant. The difference between post-operative complications like seroma, scrotal edema, wound infection, hematoma, urinary retention was comparable but not statistically significant in both the surgical techniques, and there was no recurrence found in any patient in both the groups up till the follow-up of 6 months. However, longer follow-up is required to judge about recurrence. Next. These are the references. Thank you.
So there is no statistically differentiable presentation of symptoms in either of the method as per your study.
Like, sir?
You get my point?
Yes, sir. Yes, sir. Yes, sir. Early in case of, sir, early complications, no, sir, like seroma, scrotal edema. You're asking about.
And the same applies for a chronic groin pain.
Yes, sir. Chronic groin pain is also, the difference is also not
Not
statistically significant,
statistically
sir.
significant. So what is statistically significant?
Sir, the post-operative pain which I have recorded on post-operatively on 6 hour, 24 hour, post-op day 1, post-op day 3, 7 and post-op day 15, sir. These were statistically significant. In case of invagination of sac, it was less and more in excision and ligation of sac, sir. And this
So
was statistically significant.
all this study was significant for the immediate 7 days post-operative.
Yeah, sir. Yes, sir.
After that, it is a statistically insignificant or
So yes, sir.
non-significant.
On yes, sir. On follow-up, sir, like, sir, chronic groin pain means the, sir, pain more than 3 months. That is normal tissue healing, sir. So up to 3 months or more than 3 months, sir, there was no significant difference. As I have only 50 cases to study, sir. So maybe the less number of cases,
So how
maybe
many
the
cases would
limitation.
you like to have to confirm the statistically significant ratio?
Yes, what, sir?
Hey, you said you have a 50 case study.
Yes, sir.
So you are having a problem with the statistically significant cases. So
Sir,
how
no,
many?
sir. For, sir, long-term things, sir, like chronic groin pain and recurrence rate, sir. These things like chronic groin pain, we have to. It is defined as, sir, pain more than 3 months. That is more than the time of normal tissue healing, sir. And recurrence is, sir, 6 month recurrence is like a early recurrence, sir. So time was also a factor.
So why this invagination of the sac or excision of the sac, whatever method, it is a separation of the sac, will contribute to post-operative pain and chronic groin pain? How much it contributes?
Sir, in case of, sir, indirect sac, sir, sir, recently it is believed that by some author said that, sir, after study, excision of sac, sac is a vascularized structure, sir, and it is also innervated structure, sir. So, sir, ligation at the neck and excision create a miniature peritoneus at the side, sir.
So it is, according to you, it is peritoneum which causes groin pain.
Yeah,
Okay.
sir.
So
Yes,
you
sir.
are ligating or you are invaginating for peritoneum. We keep peritoneum in preperitoneal space during surgery. So how it can contribute to local groin pain?
Yes, sir.
Because
And
it is a
also, sir,
miniature peritonitis, it
yes,
must be was visceral peritoneal pain. But how it can contribute to local groin pain? Which other factors are responsible for post-operative groin
sir,
pain?
yes, sir. Surgical dissection, sir. Some nerve
So
injury
yeah. So
and,
there
sir,
is a
entrapment
dissection.
of nerve. Yes, sir.
So dissection is the one of the major thing which affects. Okay.
Yes, sir.
So
Yes.
in case of when you want to invaginate and not ligate and excise indirect sac, you have to dissect more.
Yes,
है
sir.
ना? If you are choosing to excise the sac, you need not to dissect distal portion of the sac.
Yes, sir.
So that invagination of the sac is a preferable method for direct hernia. है ना? For indirect hernia, rather than excision of the sac is a preferable method because you require more dissection. है ना? Except some cases in which sac fundus of the sac is visible during surgery.
Yes, sir.
And there are other reasons which are causes of local groin pain. है ना?
Yes, sir.
It is the most common cause of chronic groin pain in hernioplasty.
Sir, a nerve entrapment, sir, in
No,
mesh.
it is not common. It is not common if you are careful doing surgery. So
Okay, sir.
basically, mesh is the culprit of chronic
sir,
groin
mesh.
pain.
Yes, sir.
है ना? So that they
Yes,
are
sir.
changing your pore size and etc.
Yes, yes, yes,
So how
yes.
can you differentiate these patients a groin pain due to excision of the sac or not invagination of the sac? You cannot differentiate.
Sir, actually, mesh used were same in all the cases, sir. Both the
Yeah,
groups.
for dissection, level of dissection, level of
Sir,
injuries, how you can
sir,
measure?
sir, like there is not a big difference in the dissection, sir. We in both the cases, sir, we dissect up to the deep inguinal ring, sir, up to the
Yes,
neck.
up to the deep inguinal, but
Yes.
indirect hernia, you need, if you want to invaginate the sac, you need to dissect distal portion of the sac also.
Yeah, sir.
That is not required in excision of the sac.
Yes, sir. Yes, sir.
In literature, preferable method for injection is a preferable method for direct hernia, not for indirect hernia.
Yes, sir. That's why actually we did this study, sir. To like there are many.
So
Yes.
conclusion is there: imagination should not be done.
Sir, but like.
See, this is very much important thing you should learn by presenting that which patients will you select. That is more important for
Yes, ma'am.
imagination.
Yeah. Okay, good.
Okay.
Thank you, sir. Thank you, ma'am.
This is the end of the session 4. All the participants have presented, sir.
Okay. Thank you,
Thank you
Nehal
all.
bhai. Thank you, Mukesh bhai.
Nice to meet you, ma'am, and sir. Nehal sir, nice to meet you, sir, and see you, sir.
Yes.
Thank you.
Very
Bye.
happy to meet you.
Yes, sir.
Okay, thank you very much. Thank you.
Okay, ma'am. Thank you.
Okay.
Bye.
Thank you, madam.
Bye. Bye.